Dr. Usha Shah is there online?
No. I'll call her. बुलाऊं उसको?
Hello. Hello.
Stage recording is in progress, huh?
Yes. So, good morning, friends, and welcome to this webinar of Indian Medical Association, where we are celebrating the WHO.
चालू करूं क्या?
Huh?
Should we start?
Yeah.
I think we can start now.
Have you done the opening ceremony, Dr. Girish Lad?
No. Without you, how can I do it?
You have to start.
Yes, sir.
Sir, उषा का join नहीं हो रहा है.
नहीं, कोई बात नहीं. Yeah, we start. Good morning, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for today's webinar, which we are celebrating on the occasion of WHO Day or World Health Day. It usually falls on 7th April, but for convenience, we always celebrate it on the adjacent Sunday, preferably after the day. So as you all know that last 2 years have been very critical for the entire world, but still man has always conquered nature, and man is always trying to, increase its intellect. And because of his intellect, we are able to tide over all the calamities. So today is supposed to be the last webinar under the leadership of Dr. Jitesh Mehta. So Dr. Jitesh Mehta is playing mandatory overs now, because today evening we have got an installation ceremony of the incoming president, Dr. Anil Awad, and Dr. Jitesh Mehta will be full of, enthusiasm, not because he is living, but because he has worked the whole year in a very great manner and very successfully. So therefore, I feel that those who have registered, please come for the installation ceremony in the evening, say around 6:30 or so, or 7. And now I hand over the mic to our president, Dr. Jitesh Mehta, to give his presidential address.
Thank you very much, Dr. Girish Lad. It was nice and kind of you to say such good words for me. But mind you, we are always a team. So when I am working, you are also working along with me. Otherwise, it doesn't work. So always the teamwork makes the dream work. So I thank you also for giving full support during my tenure. Friends, welcome on behalf of IMA Mumbai branch to this webinar. As you all know, as Dr. Girish Lad said, we are celebrating the WHO Day, World Health Day, and we have got some wonderful speakers. I'm sure we all will enjoy listening to them. Just a couple of things before I wind up my last address to the webinar. And that is, of course, I have always been saying that please become members of Indian Medical Association. It is the only body which is always there to look after the doctors. In spite of all this, we still have a lot of lagging behind as far as membership is concerned. So we must take this up as a priority. All those listening to me who are not members of IMA, please take this up as a priority and do become members of the Indian Medical Association. Do spare some time and effort to give your documents and the required check to the Indian Medical Association. We have seen that in the recent few days or few weeks, we have seen some bad happenings with doctors, medical fraternity. Doctors have committed suicide, some doctors are being beaten up. All this is happening more in the interiors. I feel that there should be some way of communication whereby doctors who are members should be immediately given support. So we need to do a lot of work on that ground where we can always give support to our members. In metro cities, I think we are not so badly affected, but in the interiors, there are a lot of politics, there is a lot of party pulling, and there is a lot of what can you say, dadagiri. So all that happening, and doctors are really in a bad trouble. How they are finding it very difficult to practice. People are not understanding; they are not educated, and all wrong things happen, and one leads to the other. And this was the culminating point of the medical profession, where a doctor is committing suicide just because of no fault of her own, because it was an outcome which was there, it was inevitable. It's very sad, but at the same time, we should be alert and really put our minds and thinking caps on how to prevent this again. And doctors should not, take that extreme step. It was really bad. So, friends, I leave this with this thought that you must all think how to, increase our strength as far as all our doctor friends are concerned in the rural areas also, and how we can help them in whatever way best that we can think of. I hand over the mic back to Dr. Girish Lad. Bye bye and adios to all of you. I enjoyed webinars and addressing you throughout the year, and I will be, of course, coming on the webinars always. Dr. Anil Awad will be the next president. And yeah, that's all from me. Bye.
So I request Dr. Kajal Ahuja to proceed with the webinar. Kajal?
So Dr. Kajal Ahuja will be introducing our, Dr. Kashyap Dakshini will be introducing our first speaker, Dr. Amol Kumar Patil. Dr. Kashyap Dakshini, are you there?
Good. Yes. Good morning, friends. Dr. Amol Kumar Patil is a consultant in robotic urology and kidney transplant surgery, and is attached to Aditya Birla Memorial Hospital and Apollo Hospitals. Dr. Patil did his MBBS from Grant Medical College and Sir J.J. Group of Hospitals, Mumbai, and MNA-MS Urology from Apollo Hospitals. He specializes in andrology, kidney transplant, uro-oncology, laparoscopic urology, male infertility, and has an overall experience of more than 18 years in robotic urology and kidney transplant surgery. He has been part of the renal transplant team for more than 800 renal transplants and has performed more than 450 renal transplants as primary surgeon and more than 100 robotic urology surgeries with excellent outcome. He has been an active member of the American Urological Association.
Today, Dr. Amol Kumar Patil will be talking on robotics in urology and kidney transplant surgery.
Can you allow me to share screen? Not able to share screen.
Yes.
Try again now, sir.
Yeah. My screen is visible.
Yes, sir. Please switch to full screen.
Yeah. So good morning, Mehta sir, Lad sir, and entire IMA faculty Mumbai for giving me the. Thank you very much for giving me this opportunity to speak on this World Health Day CME. So basically, sir has already introduced me. I'm from JJ only, Bombay. Finished my MBBS from Grant Medical College, MS from Bombay University, and finished my urology from Chennai and working in Apollo. So since last 5 years, Apollo is a new hospital here in Navi Mumbai. We are working for last 5 years. And today my talk is basically, most of the doctors have attended robotics in other aspects of urology. Today I will be little focusing on the kidney transplant surgery also, which is a new horizon in robotic surgery. So, as you know, urology has been long been recognized as a specialty that embraces the technologies. Because basically, if you see all the new advances, like even cystoscope, resectoscope, flexible ureteroscope, whatever the advancements, all I feel that it all started from urology itself, because the adapting this new technology and then applying their use was more common and more started with the urology. Hence, use of surgical robots also, it is dominated by urologists. Now, since the success of robotic-assisted lap prostatectomy in 1990s, it has expanded to many other domains, not only in neurology, but in other specialties. The problem is the high cost. Everybody will accept that, but in spite of this high cost, there is a very high and continuing expansion of robotic surgical procedures. It was introduced in 1990s, and that time, if you see, only from then also till 2020, means 30 years, 2022, only 15% of non-urological procedures are done by other surgeons by robotics. And urologically, if you see, now the robotic prostates, almost from 42%, it has increased to 90%. In 2003, only 43%, but now it has increased to 90%. So, urology is the branch where robotics is most commonly used. I accept that capital investment of this Da Vinci is very high and the annual maintenance cost is also very high. Now, if you allow me, I can tell you that the disposable instrument cost per instrument costs around 18 to 30, and you use around 3 to 4 instruments per case. So it goes to 60 to 90K. Means it goes higher up compared to lap or open surgery. Now, there's a comparative study done by Boland et al. That if you do a open surgery, open radical prostatectomy, it costs you around US dollars of 4,430. And if you do by robotically, it is almost double. So on average, a center needs to perform 140 to 150 cases to actually be cost effective. But still the global market is growing, and there are many competitors who are coming. There is something known as from CMR, there's a Versius logo, there's something from Medtronic Hugo, and these definitely in the near future are going to make the robotic instruments also and the robot to be used widely with a lower cost. And I hope that they will also provide the same or better surgical outcomes. Now, in urology, how it has evolved. Initially, till 75, 80s, or you can say 90s, we started we used to do open surgery. Then slowly the era of laparoscopic surgery came. And then now from 95, 2000 onwards, we are doing mostly robotic surgery. Now, why robotic surgery? I feel that I will be able to justify why robotic surgery at the end of this talk. Now, I will just brief what are the difference in open and what are the advantages to lap and compared to the robotic surgery. Now, in open surgery, if you see the advantages are the tactile feedback which you are going to get, you are not going to get in lap or robotic surgery. You can take out larger masses and organs intact, but it's very difficult to take in lap or open surgery. Highly complex surgery can be done by laparoscope or open surgery, but on robotic and laparoscope it was difficult. But having said that, by robotic surgery, now complex surgery also can be done. Now, it's if any catastrophic hemorrhage is there, very quickly you can control, but it will be difficult in lap or robotic surgery. And normally open surgery is generally quicker, so less of war time and so lower costs and more efficient use of surgeon's time also. But the disadvantage will be vision is not magnified, there will be increased blood loss, need for transfusions, increased perioperative complications, there's need for more longer hospitalization, longer time of recovery, and complications with incisions like more pain, cosmesis, cellulitis, you need a vac dressing, a lot of other things are there. Now, this is one just image, photo I want to show, where if you see the scar of open donor nephrectomy, it's such a big scar. But if you see a robotic donor nephrectomy, it's a very small and very less pain-causing scar. Now, these are the typical complications of major surgeries where you have wound complications, where you require secondary suturing, vac dressing, and all these things. These things can be avoided by using lap or robotic surgery. Now, minimal invasive surgery means we can say that laparoscopy or robotic surgery. Now, the advantage is here will be vision is magnified, blood loss is reduced, so transfusions are less, low perioperative complications, short hospitalization. So the disadvantages of open surgery are the advantage of laparoscopic surgery. But here again, loss of tactile feedback. You can't take out larger masses, cannot perform highly complex surgeries. Catastrophic hemorrhage will become difficult for you to tackle immediately. So laparoscopic surgery, we are comparing here with the robotic surgery. Now, whatever the laparoscopic advantages are there, these are the robotic surgery disadvantages. Like haptic feedback, though it's not tactile feedback, but the haptic feedback which you get with the laparoscopic instrument, you cannot get with the robotic instruments. Now, laparoscopy doesn't require commitment to rigid port configuration because you have to dock the robot in such a way that there will be no fighting between the arms, so there will not be struggle. But again, having said that, with the newer XI robot and all, this is not required again. You will have a little port configuration, a little bit flexible. Now, definitely laparoscopy is less expensive than robotics. The startup cost, buying machine and all this will be less. The other disadvantage in laparoscopic surgery, if you see, the fulcrum of the instrument lies at the port, and here the movement of the instruments are counterintuitive. If you want to want to hold the tissue and push it down, you have to make your hand up. So the movement at the port site are very high, and because of this, port site pain is definitely more compared to robotic surgery. Now, coming to robotic surgery advantages. Most important is somebody who is very well trained in open surgery and is not much trained in laparoscopic surgery, still he can do very well robotic surgery. It is not that a surgeon has to be laparoscopically very well trained to do a robotic surgery. Definitely port placement and all others, initial this thing, he has to be proficient in laparoscopic surgery, then he can do the robotic surgery. But the actual surgery as such, he need not be best laparoscopic surgeon. So what I mean is this shorter learning curve is there for laparoscopy to become, for robotic surgery compared to laparoscopy. Now, robotic surgery, if you see the vision, it is very much magnified. It's with 3D, not with 2D. Though laparoscopic 3D are also coming in picture now, but 3D vision, which is given by robotic camera, is definitely because it has double lens, it has binocular view, and it's around 10 to 15 times magnification. Another most important feature in robotic surgery is the camera assistant who is holding the in laparoscopy, he is not there. So here the camera is also held by the robotic port. So there is no any trimmer which are there in the assistant in laparoscopy. Now, if you see other things, the endorist which we see in the robotic instruments, it has got 7 degrees freedom of motion, because it will allow us to take any suture wherever you want into the deep pelvic area, or in, for example, in partial nephrectomy in different angles, which with this 7 degrees of freedom, it is all possible, but it's not possible with laparoscopy. Now, same surgeon's trimmer can be filtered off because he's sitting on the console and is doing surgery from there. So the finger trimmers can also be filtered. And fine movements can also be done by scaling down movements to 1.5x. Now, other robotic surgery advantages are, as I said, motion dampening sensors prevent the torquing at the port side, so very minimal pain. Significantly reduced conversion rate to open in compared to laparoscopy. And because the ergonomics is so good, surgeon is sitting on the console and operating, so it's very comfortable for the surgeon and he will be very, very less tired. And most important, it is the best option for morbidly obese patients. So robotic surgery will give you improved dexterity, improved vision, a better control, better precision, and with improved ergonomics, it will have a decreased putting and strain to surgeon. Coming to urology. So what all the procedures can be done in urology? Now, current urological indication, if you see, for prostate, you can do radical also, you can do simple prostatectomy. In bladder, you can do radical cystectomy, robotic partial cystectomy. So any surgery which was done in open or laparoscopy can be done by robotically now. In fact, nowadays there are robotic instruments which are coming for flexible ureteroscopy, retrograde internal surgery, which we are doing urologically. There also the robots are coming. So my experience, I just like to say that In Apollo, we have done more than, myself have done more than 100 cases. And I have done all the variety of cases, like including the most important thing here are the partial nephrectomy, radical cystectomy, and the prostatectomy, where robotic will definitely have a bigger advantage in comparison to laparoscopy. Now, we have a very robust transplant program in Apollo, and we are in fact in the last 3 years we are second to third in the Bombay city, and till date in last 4 years we have done 231 transplants, and we have done all the cadavers, also pediatric and AB incompatible transplant. And I started with robotic assisted donor nephrectomies to start with, and definitely I have seen that it has given a definite advantage compared to the laparoscopic surgery in basically pain and blood loss and tackling the vessels. So these are certain cases. If you see the upper polar mass on the right kidney, it was done by partial nephrectomy. This is a mass, around 5 centimeter mass was removed. Only partial nephrectomy, no need for radical nephrectomy here. And if you see the scar, it's a very small scar, and patient was discharged second post-op day. There's another partial nephrectomy specimen down on the CT scan. If you see the image, this is also done partial nephrectomy. So we have done robotic assisted radical prostatectomy also. These are the prostatectomy system along with lymph node dissection. Right and left lymph nodes are there. This is the prostate along with both the seminal vesicles. Oh, this was one of the horseshoe kidney, adult polycystic kidney, where patient required a transplant later on. So we have to do, for the space constraint, we have to do the nephrectomy and put the new kidney. So we have removed this robotically. There is one more case where there is a traumatic bladder rupture, and the emergency used the robot to repair the bladder. Now, more than urology, as I said, I want to focus on the kidney transplant because it's new horizon, and most of the people, even the doctors, are not aware that kidney transplant, both donor and recipient, can be done robotically. Now, donor surgery definitely is an established procedure now. Many centers are doing robotically, and results are comparable to laparoscopy. Randomized control trials have shown that robotic assisted surgery definitely has advantages like early diet and discharge, and lesser conversion to open surgery compared to laparoscopic surgery. Recipient surgery, definitely it's a complex surgery. That's why now only few centers are doing. Published data is also good. There is a good comparable outcome, and 1 year graft and patient survival also good. So these are the initial some case reports. Laparoscopic kidney transplant was done, but they found that it is very difficult. Donor nephrectomy is known, but kidney transplant was definitely difficult to do laparoscopically with the vascular anastomosis. See, other suturing becomes easy, but the vascular suturing becomes little difficult laparoscopically. Though it is challenging, can you pass on this advantage to recipients who are logically the deserving beneficiaries? Because they already have a frail habitus, they are immunosuppressed, surgical morbidity, wound infection are very high. When we do this in open surgery, definitely they go into, as I showed you, wound complications and other things very commonly. Laparoscopy is definitely, laparoscopic surgery for recipient is definitely challenging. Anastomosis become more difficult. So it requires a very high level of skill. But robotic surgery with your average skill also you can do vascular anastomosis. Now other drawbacks of such are only long in laparoscopy, the surgeon, these are all things I have discussed. I just wanted to highlight again. But one most important, inability to achieve the cold estimate during vascular anastomosis is very important, which is difficult during laparoscopy, but robotically we can do that. So these are some case studies where they have already used the robotic platform and did the kidney transplant, and definitely it has helped in the morbidly obese patients. So as I said, why it will help? Same dexterity enhancement and precision of movements, 3D vision, 7 degrees of freedom, 10 times magnification. So this robotic instruments or robot will help in addressing all these concerns which are raised in laparoscopy. It will reduce the wound related complication, reduce the pain and thus morbidity, and so early discharge. Now I will just go through about the kidney transplant and how it is different. Donor surgery is not very much different from laparoscopy, but difference is only in the port placement. As I said, lesser port side pain compared to laparoscopy, faster and precise dissection of the vessels, and minimal handling of the kidney. Same warm ischemia time, which is the more commonest concern about the nephrologist, about the warm ischemia time. So it doesn't take more time to retrieve the kidney after clamping the vessels. And also the blood loss is very less. So this is a typical OR setup for a recipient surgery. You need all these instruments. We have to get a specialized equipments which are called for making a small punch like a aortic punch, vessel punch you require, which cannot be done with a normal open punch. We have to get a specialized punch for this. And these are typical instruments, scissors, bipolar. So I'll just skip all these things. These are the typical instruments which you require. And this is the gel port which I was talking. How we put the kidney inside? We make a small paraumbilical incision with a single a gel point port. And then with this gel point port, we put the kidney inside after retrieving. And through this only, this is the typical position. Now, if you see the incision, paraumbilical incision, it's around 5 to 6, maximum 7 centimeter incision. And there are two other ports, which one port is put into the same gel point, and means we are using that gel point port also for putting other ports. So another 2 ports on the skin will be reduced. So this is the typical positioning how we do. This is the gel point port, how it is put. This is the kidney being placed through the gel point port inside, and these are the small ice sludge packages which are made through a 20 ml syringe, and they are pushed inside to keep the kidney cool. And we do the anastomosis. If you see in the image C and D, here artery and vein are being anastomosed, second artery is being anastomosed. So this is the OR setup. If you see from means away, how it is. It is our case only where we are doing the recipient surgery. Now, don't think that single port robotic surgery is not yet come. Now, people are doing. Many of the surgeons are here. They are aware about that there is a single port laparoscopic surgery. Same thing. There is a single port robotic surgery also. Now, if you see, and this is not future. This is presently done. Cleveland Clinic is doing, and in near future, India will also start. Some of the centers will start this. So they are also doing kidney transplant surgery. Leave about the robotic prostatectomy. They are doing single port kidney transplant also. So definitely there is in robotic surgery has got a advantage compared to open or laparoscopy, not only in urological procedures or mainly in uro-oncological procedure. It is also beneficial in donor and recipient surgery. If you see the size of the incision, left hand corner, if you see it is more than around 13 to 14 centimeter, and here if you see it is 5-6 centimeters. And it matters a lot in transplant recipients because these are all immunosuppressed patients. They are on steroids, and there's very, very high chance of wound infection and wound related complications. So thank you very much. If time permits, I will, Madam, time is there, then I will show a small video of this thing, donor nephrectomy.
Okay.
So this is the donor nephrectomy. Meanwhile, if any questions are also I can take. So this is the monopolar curve which I was talking on the right hand. Left hand is the fenestrated bipolar grasper. And I'm just trying to mobilize the colon from the kidney. This is the descending colon, which is on the, and we are doing a nephrectomy on the left side. I'm just mobilizing the colon down. Left side, you can see up is the spleen. So splenorenal ligament and splenocholic ligament we are separating. I'm trying to, that is the psoas muscle. I'm trying to see the iliacs and then the ureter and the gonadal vein. So if you can see, that is the gonadal vein. That the ureter has been hooked up. This is the ureter. So spleen is being mobilized up to see the upper pole of the kidney and mobilize. So this is the adrenal vein, which we are trying to tackle it. This is the renal vein, and to that attached is the adrenal vein. So I was just clipping the adrenal vein. So why I'm showing this is sometimes this becomes very difficult when you're doing laparoscopically, this tackling of the instrument, dissection. but it becomes very easy with robotic surgery because the curve of the scissors, you can move it to 95, 100 degrees, and you can bend downwards, upwards, in whatever way you want. So it's more than advantage to the, it is definitely advantage to the patient. It's a big advantage to surgeon also. So this is the adrenal vein being tackled. In a radical or any simple nephrectomy, because we are going to not use that kidney, so dissection and this thing can be little harsh. But here we are going to use that kidney, that vein has to be anastomosed, that artery has to be anastomosed, so it has to be very gentle to use this. Now this which I was talking about, this is the lumbar vein. Lumbar vein becomes such a simple task when you're doing robotic surgery in compared to laparoscopic surgery. So lumbar vein, it has got one more branch there which is going inside. So this has been like vein has been dissected. Now behind is the artery. Artery is now being dissected. Lumbar vein is still not completely ligated. There's one more branch which is going down. So we are trying to dissect the artery to make sure that we don't put the clip on the artery. So artery is completely separated, and then we are putting the clip on the renal vein. The vision is very clear here in the robotic surgery as compared to laparoscopic surgery. See, there is one more vein behind the lumbar vein, which is also, it was causing us a trouble. So this is the lumbar vein being taken care, and just where his assistant is suctioning is the artery. So this is the artery, this is the vein, and we are almost ready with the now clips for the artery and vein. So the ureter we are going to take now. That below is the iliac artery. At the crossing of the iliac vessels, we are taking the ureter. We'll cut the ureter later. Now I think you can very well see the artery, vein, the kidney up along with the fat, and the defatting will be done on the bench. A very small incision will be taken to retrieve the kidney, and it will be taken just by the side of the assistant port, so that that port will also be utilized in the incision. So artery being divided, we don't cut put the clip on the kidney side of the artery. So the kidney is completely removed now. The upper pole is little dissected. Almost it has been prepared, and the one small hand, with a small incision, we put a hand and take out the kidney. Thank you. I think now I would be taking any questions if.
Good morning, sir. Dr. Anil Awad here.
Good morning, sir. Yes,
sir, there is one question.
Yeah.
What is the total cost of robotic surgery? And there could be another sub question asked in the chat box. What is the cost of robotic kidney transplant surgery?
So, kidney transplant surgery cost at Apollo is 6 lakh rupees. Whenever we are doing robotic surgery, the extra, we are not charging additional extra for the surgeon or the this thing. We are only charging extra for the instrument and the consumables.
Yeah.
So it costs around 1 lakh rupees extra. If you say donor nephrocopy, it costs only 50,000. But when you're doing recipient, because 4 to 5 instruments will be used, so it will cost 1 lakh rupees extra as compared to 6 lakh original package.
Okay.
Dr. Patil.
Yes, sir.
You said that the learning curve of robotic surgery is less than that of laparoscopic surgery.
Yes, sir.
How is it so? How is it? How do you justify that? I mean,
see, sir. So the steps
of
of
instruments and all look so complicated. We feel that it is requiring more and more of learning.
No, sir. When you are sitting on the console, I have not shown you that image probably. When you are sitting on the console, it is very easy, sir. Because laparoscopic surgery, you need definitely skill because your hand itself is using those instruments, the trimmer and all these things. But when you are sitting on the console, the same steps when you are doing in the open surgery, those steps will be replicated sitting on the console, sir. That's why you need not be that proficient laparoscopic surgeon to do a robotic surgery.
But then you should be proficient in doing video games when you are young, no?
Basics of laparoscopic surgery should be there because it is the same technique. You have to do pneumoperitoneum, putting the ports, all these things will be there, sir. So basics of laparoscopic surgery, he has to be proficient in that. But as comparatively, if we are doing a skillful laparoscopic, suppose a laparoscopic surgeon wants to do a kidney transplant laparoscopically, average laparoscopic surgeon, it's very difficult, sir. But if an average open surgeon also who is doing a transplant and doing vascular anastomosis, it will be easy for him to do a robotic recipient surgery, vascular anastomosis.
Okay.
Thank you.
Now only cost is a
thank you very much.
I don't think anything because you see all the branches are utilizing now robotic surgery, sir. And definitely with the coming Medtronics and this thing, the cost is definitely going to come down, sir. These people are in Da Vinci charging around 18 to 30K per instrument. Medtronics is coming with 10,000 per instrument, sir. So the cost will go around 30-35,000 only over the instrument. So 50% reduction in the cost. Over a period of time, initially when the laparoscopy came also, all the surgeons were little like, oh, open surgery is better than laparoscopy. Why laparoscopy?
And goes by, the cost will come down.
Yes.
Thank you.
Okay. Thank you very much, sir. There are no more questions. I don't see any questions. Thanks a lot. And there's one comment on chat box. Awesome, almost impossible. So that explains the work what you are doing. Unbelievable. That is what is written. Thank you very much, sir. And now we move on to the next section. That is Dr. Preeti Doshi. I request Dr. Kajal Ahuja, Assistant Secretary, IMA Mumbai Sub-Faculty, to introduce Dr. Preeti Doshi.
Morning. Dr. Preeti Doshi is Director and in charge of the pain clinic at Jesloke Hospital and consultant in pain management at Bridgecandy, Wokhart, Bhatia, and Sefi hospitals. She passed MBBS and MD from TN Medical College, Nair Hospital, and FRCA from Royal College of Anaesthetists, London. She was the senior house officer in the North Middlesex NHS Trust Stirling Way, London, and lecturer in anesthesiology, TN Medical College. Her other academic qualifications include FIPP and FIAPM. She is also the secretary of the Neuromodulation Society. Her specialty is pain management and she has an overall experience of 24 years. Her areas of interest include neuromodulation, regenerative medicine, and spine pain. She has to her credit many publications in index journals and has authored articles in textbooks, national and international journals. She has been an invited faculty in national and international conferences and on advanced pain therapies. She is a recipient of Pain Ambassador Award at ICRA in 2019. Today, she'll be speaking on recent advances in pain management modalities. Over to Dr. Preeti Doshi.
Am I audible?
Yes.
Yes. Good morning, madam.
Good morning. I'll just
Hi.
start. Can you please allow me to share my screen?
Yes, sir.
A very good morning to all. Thank you, Dr. Ahuja, for that wonderful introduction. And congratulations to Dr. Jitesh, Dr. Jitesh Mehta, Dr. Lad, and all the organizers for arranging this wonderful CME on the occasion of World Health Day today. So I'm going to highlight some of the recent advances in the field of pain management today. Pain, as we all understand, it is an unpleasant sensory and emotional experience associated with, or now the wording which has been added to this definition by the IASP task force in 2020 is it could be resembling that associated with actual or potential tissue damage. So we need to keep in mind that pain is not just a symptom for which the patient seeks medical attention, although it is the commonest symptom which will warn you that something is wrong with the body and you would definitely seek medical attention. But it, in fact, can be an aggressive neurological disorder. And unfortunately, we do not have any objective method to quantify pain or to measure pain, and also to distinguish between different varieties of pains. There are various classifications described in the literature, such as somatic pain versus visceral pain, nociceptive versus neuropathic versus a newer variety, which is called nociplastic pain, acute versus chronic pain. I would just like to brief you all that the specialty of pain medicine or algiatry is a discipline in the field of medicine which addresses the issues like prevention of pain, evaluation, treatment, and rehabilitation of persons in pain. I'm sure all those here in the audience at some point have experienced some kind of pain, but the fortunate thing is most of the pains have a self-limiting duration. However, when it goes on lingering beyond a period of 3 months, it is labeled as chronic pain, and that is when it becomes a real challenge. So we have something called interventional pain management, which includes minimally invasive procedures, which are by and large performed by a percutaneous manner by guiding the needles precisely to the targets where the effect is required. And you could either place drugs or an electrical stimulation. And this is used for diagnostic, therapeutic, as well as prognostic purposes in patients who have chronic, persistent, intractable pain. And we have to accept that chronic pain is a hard reality of life. And many of us here, besides the acute pain, have also experienced some kind of chronic pain at some point. And there can be a variety of reasons why one could have chronic pain, right from the headaches up to perennial pain. Low back pain, of course, is one of the commonest problems that we see in a practice of pain clinic. Osteoarthritis, most commonly of the knee joint, is again a very common problem. Facial or cervical pain often can be very distressing. So conditions like trigeminal neuralgia, which can in fact, which have been described as suicide disease. So the pain can be so intolerable that the patients may be compelled to have such thoughts as well. There is something called complex regional pain syndrome, or a reflex sympathetic dystrophy, as it was known earlier before 1994 when the term CRPS was coined. And this is a condition, again, very often seen in orthopedic practice when the patients have fracture and prolonged immobilization. So when the cast is removed, the original pain is gone, but they have a very different kind of pain, which is often very distressing and which does not respond to the standard line of management. Then we have pain which can occur due to peripheral vascular diseases, and some of the cases which cannot be offered surgical therapies can be very effectively managed again in pain clinic. Chronic pancreatitis again is a very, very commonly seen problem. Pelvic and perineal pain, again the incidence that I see nowadays in many young females, there is an alarming rise in the incidence of pelvic pain with problems such as endometriosis, adenomyosis, and so on. Shoulder pain, patients having pain after an acute attack of herpes zoster has healed, which is described as post-herpetic neuralgia. Chronic post-surgical pain. This is again a very popular entity nowadays, often seen in patients who've undergone common surgeries like hernia surgery or a mastectomy or a cholecystectomy. And this again can be quite a challenge in clinical practice. Musculoskeletal pain and fibromyalgia pains are also very commonly seen in the practice of pain management. And as I mentioned, headaches and migraines again are very commonly seen. And last but not the least, cancer pain. So we all know that pain is an essential part of the package of cancer pain. And that is where, again, a role of pain management clinic can be quite useful. So remember, chronic pain can be crippling because pain is not just a symptom. As I said, it is an aggressive disease. It's a complex process with a pathophysiology which is again quite difficult to understand. There is a lot of research going on. Still, we do not completely understand how chronic pain happens. And it is known to have two components, physical as well as psychological. It can seriously affect your activities of daily living, social life, as well as ability to perform work satisfactorily. It affects your sleep, appetite, concentration ability, and mobility. And as Sean Mackey, a renowned pain physician from Stanford University, said, chronic pain is not only about body, it is about the brain, it is everything. So we have to target everything and take back your life. So what I want to highlight here is that what we need is a multidisciplinary and multimodal approach to take control of chronic pain completely. And almost 10% of individuals who commit suicides have some kind of chronic pain. So that often can be a cause of real distress in somebody's personal life as well. So biopsychosocial model of chronic pain is what we need to remember. So in addition to the biological component, we often have psychological effects and also leading to impairment of the social interactions, and that overall can impact the well-being of the sufferer. So what we need to understand is that we need what is called as a total pain management, with pharmacotherapy or drugs forming the mainstay. However, there are a number of other components which are equally important, including physical or occupational therapy, psychological therapy, lifestyle management measures, stress management, and of course, interventional management, which also I'm going to highlight in my today's talk, biofeedback, surgical interventions wherever required, and complementary therapies also have a role. So they all go hand in hand, and we have to offer comprehensive therapy and by a multidisciplinary, multimodal approach to achieve the best possible outcome. In pain clinic, we generally follow an algorithm where we establish a working diagnosis, and we then gradually move on one by one, stepwise, starting with simple therapies initially. If they do not help, then we progress to the second tier pain therapies in form of various interventions, radiofrequency ablations, neurolytic procedures, nerve blocks, and even to the extent of going and prescribing ongoing systemic opioids. And if all of this do not help, then we have the last tier, which is termed as the advanced pain therapies, which involves implantation of hardwares to help pain on an ongoing long-term basis. So coming to pharmacotherapy, as I mentioned, it is the mainstay, and we have to follow certain important principles here. We need to understand that chronic pain can be multifactorial nature. It can have different mechanisms. So always try and understand the mechanism, and we offer a mechanistic, multi-mechanistic approach in a stepwise manner. We have to obviously do a thorough clinical evaluation with the help of history examination and as appropriate investigations. As regards to the drugs, we have to always think in a rational manner as to what is the most likely mechanism and prescribe the medications to target that particular mechanism. We always start in a low dose, go up slowly and titrate the drugs to either a level where it is efficacious or whether if the patient develops any side effects. We also have to give special considerations to patients who have limitations in form of some comorbidities like renal failure or hepatic failure or geriatric age group or pediatric age group. So generally, the analgesic drugs based on the mechanism can be classified into either simple analgesics, non-opioid analgesics, and opioid analgesics. And they work at different levels, right from the periphery at the level of nociceptors, going on to the dorsal root ganglion, the pain pathways, the brain centers, and finally the cerebral cortex. So for nociceptive pain, which is generally the somatic pain, as it occurs in either post-surgical period or after an injury, we would start with simple analgesics initially, which I'm sure all of you know. So if that is not adequate, then we move on to milder opioids in form of codeine, tramadol, or even now we have something called tapentadol, which is moderately strong. And that can be used in combination, obviously, with the simple analgesics to give a synergistic effect and control moderate levels of pain. If that is not also adequate, then we move on to the stronger opioids in form of morphine and fentanyl. As regards to neuropathic pain, which is generally the nerve-related pain, we have 4 categories here. We have anticonvulsant drugs like gabapentinoids in form of pregabalin and gabapentin. We have antidepressant drugs like tricyclic antidepressants and serotonin noradrenaline reuptake inhibitors. We have antiarrhythmic drugs like lignocaine and mexiletine. And then we have many other supportive or adjuvant drugs, which are not actually used for pain, but they enhance the effect of analgesic drugs when they are used as co-prescriptions. So in cancer pain, again, we have to keep certain principles in mind. We know that cancer is generally a progressive disease, and in the palliative care for pain management, what we have to keep in mind, we again go generally by the WHO ladder, wherein we move on to stronger drugs if the patient does not respond to the simpler drugs. We have to try and use the oral route of administration wherever possible. Remember, we have to give the drugs by the clock. So there is no role for SOS medication here generally. We have to give the patient round the clock medication to prevent breakthrough pains. And then as and when there is a pain which breaks through because of the progression of the disease, we may have to consider giving appropriate breakthrough doses as well. So the pain management and the pharmacotherapy for cancer pain has to be individualized to best suit an individual requirement. And depending on their comorbidities or other problems, we have to adjust the drugs for each and every individual patient. Remember, we do have alternate routes also when oral route is not possible. So in the recent times, we have wonderful patches or transdermal preparations with which the compliance is much better and the patient can get efficacious pain relief for a period of up to 72 hours to some of the patches which work for 7 days. We do have nasal preparations also, and we have a tapentadol spray in the recent time, which can be again used for breakthrough pains. We have per-rectal suppositories. We have oral transmucosal fentanyl citrate or a lollipop. We have then neuraxial route where we use a very small concentrated dose of the medication into the spinal canal, either into the epidural space or into the subarachnoid space. And then we have external devices like this as shown in the picture. These are the either elastomeric pumps or electronic pumps with which we can deliver a steady rate of drug at the level of spinal cord, and that can give ongoing and very efficacious pain relief. So as I mentioned, fentanyl patch has really been very useful in the recent practice. So especially for the cancer pain patients, it's very, very useful. It generally has 4 layers. So we have an adhesive layer. Once we remove that, it is to be adhered on the patient's hairless area. It can last for as long as 72 hours. There are certain precautions which we need to take care, and this is what we give to the patients when we put them on patches. It is available in various strengths, even in a smaller strength nowadays for patients who have comorbidities and whom we cannot give large doses. There is also another patch which lasts for almost 7 days, and however, this can have a ceiling effect, but it can be preferred for certain indications like non-cancer chronic pain. So what is important to remember is to adhere to what we call as multimodal analgesia, and this is to achieve an improved anti-nociception due to synergistic or additive effects. And thereby, we aim to reduce the dose of each individual analgesic drug and reduce the severity of side effects of, again, each individual drug. In the recently, the Journal of Pain Medicine, there was a review article published in 2019 where this is the algorithm that is followed for patients with neuropathic pain. So we obviously start with pharmacotherapy, move on to simple interventions. If they do not help, we move on to the advanced pain interventions and opioid drugs. The low back pain, it is again divided into non-specific back pain, which occurs in majority of patients, 70% patients, and mechanical back pain and non-mechanical back pain, and pain which can also due to visceral diseases as well. So what I want to highlight here is a problem of persistent spinal pain syndrome. Now, this is a problem which occurs in patients who have undergone previous back surgery and they persist to have pain. And this, unfortunately, is a very, very common problem which can occur in almost up to 30 to 40% of individuals who undergo spinal surgery. Foraminal stenosis can occur in almost 30% of patients, which can go undetected, unaddressed, and result in persistent pain. Painful disc, which can also occur in almost 20 to 22% of patients. Pseudoarthrosis, neuropathic pain, recurrent disc herniations, iatrogenic instability, facetogenic pain, and SI joint pain are some other causes. And perineural fibrosis, which can occur in almost 60% of the patients who undergone multiple revision surgeries. This can be quite a difficult problem, and I'll show you how we can address it in the practice of pain management. Cervical region, again, is one of the most mobile region in the spine, and so that can be very commonly a source of pain. Cervical facet joints result into pain in almost 50% of individuals. 20% of patients can have intervertebral disc-related pain in the cervical spine region. The other sources resulting into pain could be nerve root, dura, vertebra, joints, oncovertebral joints, muscles, and fascia. So we have a gamut of interventions which can be offered to the patients with spinal pain, either of cervical origin or lumbar origin. That, depending on an individual patient and an individual pathology, we decide which one to offer. So again, this is performed under fluoroscopic guidance with the patient in the operating theater with all sterile conditions. We target the, as you can see here, this is a transforaminal epidural injection, which is currently advocated in the most of the patients. We have something called failback surgery here. You can see the implants are in situ and still the patient has so much pain. We have to introduce a special spring-loaded radio-opaque catheter under fluoroscopic guidance into the target where the effect is required, and we deliver medications in that area. This is a cervical spine, again, where we can do either a cervical epidural. And as you can see, this is the drug which is spreading into the posterior epidural space. We also have something called medial branch block or facet blocks for patients who have facetogenic pain. And this is very common in patients who have vehicular accidents on the road or road traffic accidents, especially the high impact accidents. Patients who have vertebral origin pain, we can do something called vertebroplasty or kyphoplasty. Coming to the radio frequency denervation, which is offered with a machine like this, radio frequency ablation machine. And this can be, again, this produces a neural destruction by delivering thermal energy. This is very effective in patients with trigeminal neuralgia, cervicogenic headache, where we do occipital nerve RF ablation, intercostal pain, patients with thoracic wall pain. We can do intercostal nerve radiofrequency ablation. And very common condition which we see in clinical practice is lumbar or cervical facetogenic pain. Again, this modality can be very useful there. So we have a special machine. We again do it under image guidance. We have specialized Teflon coated needles with a bare tip where a lesion is produced. As you can see, this lesion which is produced in situ, and this is the ellipsoid lesion which is produced at the tip of these special needles. This can also be applied in patients who have discogenic pain with contained disc herniation or thoracic facet pain. And cervical cordotomy is a special technique, again, provided with this machine for patients who have severe unilateral intractable cancer pain. Nowadays, we again have a newer modality in our armamentarium called a cool tip RF ablation. There is a specialized machine where the temperature at the tip of the introducer needle is not allowed to go beyond 60 degrees. And this effectively has been shown to produce a lesion which is 5 times larger in volume as compared to the standard radio frequency, with a better chance of covering for any anatomical variation. We also have something called cryoablation, which works on the principle of freezing at the tip of the needle to minus 180 degrees centigrade. And that again can produce something called an ice ball at the tip, and that produces cryoablation of the target nerve. This can be effectively used for patients with occipital pain, intercostal, ilioinguinal, iliohypogastric nerve involvement pain, obturator encephalous neuralgia, and also can be used for facetogenic or knee joint related pain. In the recent times, we also provide what is called as genicular nerve radiofrequency for patients who have chronic osteoarthritis pain of the knee, where either there is no role for TKR or whether TKR has already been done and patient has developed knee pain subsequently and there is no scope for any further surgery. We also have something called non-invasive neuromodulation, where we aim to produce neuromodulation at the central level. And this is found to be quite effective for patients who have primary headache syndromes, which are intractable to all other simpler treatments, fibromyalgia pain, and chronic pelvic pain. So there is a device called transcranial magnetic stimulation, which is there's a special chair with a special headgear which is applied to the patient's head, and they are giving repeated sittings for 20 to 30 minutes on 5 consecutive days or 10 consecutive days, and they are found to be quite effective. So this is one of the non-pharmacological method of controlling pain. And in the recent times, we have something called a vagal nerve stimulator. So neuromodulation, as I mentioned, is a very, very useful modality. And at our center, we practice neuromodulation of all kinds. Basically, we try to achieve modulation of activity of central, peripheral, and autonomic nervous system by delivering either a small voltage electrical stimulation or a pharmaceutical agent directly over the target area, which is generally the nerve cells in the spinal cord or a peripheral nerve, by means of an implantable device like this. So there is a catheter which goes into the intrathecal space, connected up to a programmable, very sophisticated pump, which can be refilled with the desired drug that we want to administer to the target area. And then we have something called a spinal cord stimulator, where a special wire such as this shown in the picture here is introduced into the dorsal epidural space, and it's connected up to a pacemaker-like device, which is called an IPG. And this can again be provide ongoing analgesia to patients who have severe intractable neuropathic pain. USG or ultrasound guidance has proved to be a very useful tool in the recent times. And the thing is that we can actually visualize the spread of the local anesthetic or the drug that we are injecting in real time. And these procedures can be very conveniently done on OPD basis as well. So patients just walk in and walk out, and we do the nerve blocks and give them pain relief. So this, the benefits of ultrasound, again, it reveals the soft tissues very beautifully. It gives us real-time imaging. We can adjust the direction and the depth of the needles to the target, and we can actually visualize, as I mentioned, the local anesthetic spread in real time as well. So there are several applications of USG guided interventions, right from the peripheral nerves, sacroiliac joint injections, facet injections, knee and shoulder injections and blocks like erector spiny block. This is one of the newer blocks which can be very effective in patients who have a chest wall related pain. As I mentioned, intra-articular knee injections, again, when performed under ultrasound guidance, are proven to be much more effective as compared to blind injections. Coming to the next modality, which is regenerative medicine, which is being talked about in various fields. So there is a lot of application even in the field of pain management, starting from platelet-rich plasma to bone marrow aspirate concentrate, to exosomes and many other newer versions as well. So what is platelet-rich plasma? Basically, we concentrate autologous blood sample, which is drawn from the patient's own vein, and that is then concentrated by a centrifuge machine as such, after adding CPD as an anticoagulant, and thereby we try to obtain a concentrate of platelet, which is very rich and has abundant growth factors, and that is then injected into the target tissues like soft tissues which are inflamed or intra-articular joint injections. And we have a number of expanding indications for platelet-rich plasma as well, right from shoulder injuries to sports injuries such as wrist and hand injury, elbows like golfer's elbow, tennis elbow, back and hip injuries in knees, ankles, foot like plantar fasciitis, etc. I'd like to just illustrate now with some clinical cases. So this was a 36-year-old female who had bilateral hip joint pain, severe in intensity, which was radiating to thighs and groins for a period of almost 6 months before I saw her. And she had extremely severe pain, as I said, 10 on 10. We were debating as to what could be the likely diagnosis, whether it was SLE, Raynaud's disease, some autoimmune vasculitis. And she was, on a number of painkillers without much benefit. She also underwent a bilateral hip cord decompression in September 2020, 3 months before I saw her, without much benefit. So this lady, I performed what we call as a bilateral hip radiofrequency ablation of the obturator nerve and the articular branch of the femoral nerve, with excellent relief and restoration of her mobility and ability to do day-to-day activities. A 65-year-old female, again, presented with severe chronic pancreatitis pain, 9 on 10 intensity with a significantly impaired quality of life. Unfortunately, this lady was on twice-a-week hemodialysis because of her compromised kidney function, and she was not able to take the regular analgesics which we would give to a patient with chronic pancreatitis. So a bilateral splanchnic nerve radiofrequency ablation, as you can see here on this picture, at the level of T11 and 12, we place the needles, we confirm the placement of the needle tips by injecting a small non-ionic contrast, and then we perform radiofrequency ablation. And this is all done in OT under local anesthesia in a percutaneous manner with excellent outcomes. So this can be a real, this patient got complete relief of her pain. She went off all the simple analgesics, even the drugs like paracetamol, which she used to take off and on, and she was really grateful for this degree of pain relief. Another 17-year-old young boy, he was appearing for his CBSE examination, and he presented to me with severe pain in the left anterior chest wall in the region of 2nd to 4th rib. He was actually referred to me by a rheumatologist who had tried him on various painkillers, ruled out everything, and there was nothing that could be done in terms of any drugs by her specialty. So he obviously tried everything possible under the earth, and him we offered what we I described earlier as an erector spiny with PEC1 and PEC2 block. This is done again under ultrasound guidance on OPD basis, and the patient got excellent relief, almost more than 80%. And along with physiotherapy, he became completely pain-free, and he was able to do his CBSE examination, passed out with flying colors, and could resume studies, and he could opt for a career of his choice. So he was really, again, one of the very happy patients. This was a gentleman who had 42-year-old young businessman who had headaches since the 1996. So before I saw him in 2008, he suffered for a period of almost 12 years. He had headaches, daily headaches, which were present for almost 25 days in a month, generalized throbbing, severe intensity along with all the features of migraine. He had great difficulty in his day-to-day activities, and he was highly disabled because of the severity of headaches, and he was losing out on his contacts and customers. So he practically tried everything, including botulinum toxin injections. Nothing seemed to have worked. So we considered him as a candidate. And after counseling, we offered him what we call as an occipital nerve stimulator, where we implant an electrode over the occipital nerve. We do a stimulation, and then that is connected to an IPG or a pulse generator. And he had an excellent result. This patient not only went off all the analgesic drugs which he used to take. He used to take a whole range of anti-migraine drugs. In addition to that, he, after a period of about 1 year, he even stopped using the stimulator because he said every 3 months when I get some headache, I switch it on and I get the desired relief. I don't need to take any breakthrough drugs, any triptans, or not even use the stimulator on a continuous basis. So this basically was successful in switching off the mechanism which caused his severe headache, and was one of the very rewarding indications that we came across. A 34-year-old female patient who had a full-term normal delivery under epidural analgesia just a month ago presented with severe positional occipital headaches, bilateral, with severe neck pain. And this lady was referred to me by my colleague neurologist. The patient had significantly impaired quality of life, and when the demand of nursing the baby was so high, she was not able to even sit up to feed the baby. And we ruled out obviously all the other causes. She was given all simple analgesics which were permitted in a lactating woman without much help. So we did MRI of the brain and the spine, which showed hyperintensities at the C2 and C5 level of the spinal canal, and that was suggestive of CSF leakage, and the diagnosis of spontaneous intracranial hypotension was made in this case. So this patient, I did a targeted cervical epidural blood patch where we drew the patient's autologous blood and injected about 5 mL at each level, C2 and C5, with instantaneous relief from the headaches. And this patient is so grateful because after this, she has not even required a single drug, and she has been able to enjoy the motherhood and doing all her day-to-day activities which she required to do. Another 69-year-old female patient who had severe pain in the right upper extremity with progressive increase in intensity over a period of 1.5 years. She actually happened to have a schwannoma of the upper trunk of the right side brachial plexus, which had been excised by a neurosurgeon 2 years back with a relief which lasted for about 6 months. And she presented with severe sharp shooting pain along with severe burning in right side upper extremity in the C4, 5, 6 distribution with very severe intensity. She obviously had tried all analgesic drugs, different anti-neuropathic pain drugs, and she typically had features of complex regional pain syndrome type 2, which I described as, it could present as severe burning, intermittent swelling, discoloration, and that became worse with the exertion and activities. And this was present in her dominant hand, which is the right upper extremity. So it was extremely disabling again. We did a repeat MRI scan to rule out that there was no schwannoma recurrence. That was established. And then we gave her simple interventions in form of a stellate ganglion block, which of course gave her some short-lived relief, but the pain and the symptoms used to come back again. And this was greatly affecting her functioning ability and quality of life. And we decided to do a trial of spinal cord stimulator for this lady. So again, as I mentioned, this is a percutaneous placement of a special 2He needle, which is used to locate the epidural space. And then we have a special wire or a special lead, which has different electrical contact points. As you can see in this X-ray, again, the procedure is done in OT with X-ray guidance, with continuous C-arm guidance in lateral views. And we place the lead on the affected side. That is then tunneled and connected to an external device with which we give a trial period. And during the trial period, we judge how much is the benefit that the patient is achieving. So if the patient has satisfactory pain relief without any side effect, we then move on to proceed with implanting the pacemaker. And this is the same lady that we implanted almost early in 2010, and this lady followed up in 2020, just before the COVID started. She came back for a follow-up, and she's still using the device very effectively, and is extremely happy with the great improvement in the function of the right arm, control of all her symptoms of CRPS2, and she's able to live a completely normal life and able to do all the activities with her dominant hand, which she always wanted to do. So these are some of the happy faces. So I can say that, for pain relief, we need to do a detailed evaluation to take into consideration all the biopsychosocial aspects for instituting the most appropriate treatment for pain. We have to individualize the pain relief for each and every patient and advocate as far as possible a multimodal, multidisciplinary approach. Timely management of pain can greatly improve the outcomes. Minimally invasive outpatient procedures for a variety of pain conditions are displacing the invasive and expensive surgeries associated with prolonged recovery period. And we have multiple nuances which are promising to improve the long-term control of pain. So pain relief is a basic human right, and we should always keep in mind for all our patients to have adequate control of their acute as well as chronic pain. Remember, treating chronic pain patient is like fixing a car with 4 flat tires. You cannot drive a car with just one inflated tire and expect a good result. You have to work on all 4 tires to get a complete comprehensive control of pain, and what we call as total pain management. Thank you so much for a patient hearing. So with that, I would like to stop sharing my screen, and I'll be happy to take questions if any.
Yeah, wonderful lecture, madam. It was really because the pain is something which comes to everyone's clinic day. I mean, every moment, and either it is acute pain or chronic pain. So we all must be benefited with your lecture. Thank you very much. I'll go to the question. Which selective COX-2 inhibitor can be used for routine pain management?
Okay, so I think I'm sure everybody's aware here that we had a controversy about rofecoxib and valdecoxib, few years back. So nowadays, etoricoxib is one which is available quite freely, and I'm sure it is used very commonly in the orthopedic practice as well as practice of pain management or rheumatic practice as well. Rheumatology practice, and that is fairly safe to be given again in select patients. Once you rule out all the contraindications, it's much gentler on the stomach lining, and from the gastritis point of view, again, it is quite good. And we have a variety of brands available along with combinations with muscle relaxants or paracetamol as required for an individual patient. So I use etoricoxib quite widely in my practice.
Which pain inhibitor is safe during pregnancy?
So actually, I mean, of course, we have to try and adhere to non-pharmacological methods as far as possible, especially in the first trimester. But if the patient does not respond, then paracetamol is one which is, again, quite safely and commonly given by the obstetricians as well. And I am sure the pediatricians also would agree with me that, paracetamol is one drug which is quite good. Now, in patients, it becomes challenging in somebody who's got chronic migraine or who has neuropathic pain. And for those conditions, again, first trimester, we have to try and manage as far as possible, either with external therapies or non-pharmacological therapies. But if we have to use, then with calculated risk, we can give gabapentin. Gabapentin is considered to be one of the safest. Of course, nothing is 100% safe, but compared to the others, you can kind of consider giving gabapentin if required.
Can plain paracetamol be given?
Yes, plain paracetamol is absolutely fine. And actually, even in the second or the third trimester, rather, if required, if there is gross inflammation and if you need to give, non-steroidal anti-inflammatory in form of diclofenac, but as short period as possible, and ideally, of course, as I said, we have to manage without any drugs, but if one has to give, then we may need to weigh the benefits versus the risks and give the medication.
Yeah. Again, a very commonly asked question, which are the safest painkillers within kidney compromised patients?
Sure. So again, I think I would say non-steroidal anti-inflammatory drugs should be avoided strictly. Paracetamol can be given within the set dose limit. Of course, one cannot exceed the dose of paracetamol also. So try and minimize the dose as much as possible. We have drugs like tramadol or even the fentanyl patches or the buprenorphine patch. They are fairly safe in patients who have compromised kidney function. Again, as I said, we always advocate a comprehensive approach. So wherever possible, if we can be permitted to do some nerve block or target the nerves and control the pain, that has to be also used as an adjunct along with giving medication.
So,
yeah.
can I ask a question?
Madam, can I ask one question?
Sure.
Nowadays, you told about the PRP. It is much more in use. Mostly the skin specialists are using so much. Is it equivalent to stem cell?
No, actually, I mean, there is a difference, definite difference and definite difference in indications also. Stem cells would probably have a better potential into differentiating into the type of degenerated cell, and that can definitely, in my opinion, give a better outcome. But as we don't have stem cells very widely available right now, PRP is an option and has been used effectively and has been found to be quite useful in many of our patients. So at the moment, we have PRP, which is very easily available and which is practiced for many indications, including, as I mentioned, the whole list of conditions in pain management also.
Okay.
Madam, you said that we are getting so many cases of chronic pain where no drugs are acting, especially arthritis pain, all that. And so when you say that these people can be benefited with procedures, what are the cost factors that we are looking at when they come for the procedures?
So as I mentioned, nowadays we do many procedures as on ultrasound guided assistance, and these are like OPD patients. So they don't need to be admitted even in daycare. They can just come to the sonography department where we do these procedures, and the procedure takes 15 minutes to 30 minutes, and we just observe them for another half an hour or so, and they are ready to go. So it involves very less time, and cost-wise also, the cost is for some minor procedures will be anywhere from 10 to 15,000. But if they have to be admitted on daycare and if they have to be taken to the operation theater, because we don't do it anything in a compromised manner, we do it in the most meticulous and structured manner. So we do it in a hygienic manner, always in the operating theater, which is the main operating theater where all the joint replacements and other major surgeries take place. And so that involves the cost of the OT, sometimes the radio frequency equipment we have to use. So depending on what procedure we are doing, the cost can vary anywhere from maybe 30 to 40,000. It can go even higher, up to 60, 70,000 as well. So it all depends on how much time we consume, how many levels we have to cover, depending on an individual patient.
Madam, what about the PRF? Mostly the dentists are using so much for during implant.
Yeah.
How far it is benefited?
So no, I don't use PRF. PRF is the
Plasma-rich factor.
Yeah, so that no, we use PRP, and we will be starting other products as well very soon at our center. But as of now, we are doing only PRP. So PRF, I don't personally use in my practice.
Okay.
Hi, ma'am. Dr. Kashyap here had a quick question. on occipital nerve stimulation. So
Yes.
you've spoken and the use of occipital nerve stimulation for migraine treatment.
Yes.
So how big would be the device, and are there any side effects? What would be the cost, and how much is the procedure time? How long does it take to implant that device?
Sure. So obviously, we will select our patient correctly by making sure that they've tried every possible option, including botulinum toxin. And if they get very short-lived relief, or if the pain is recurrent and very severe, then we select them for doing the occipital nerve stimulator. Now, occipital nerve stimulator, basically it involves a very thin wire with different contact points. So metal contact points, as I showed in my picture, it's like it has an insulated coating of a wire and only very small contact points at the end. They come in different configurations. So either 4 contact points or nowadays we use the 8 contact point lead that is introduced percutaneously. But it has to be done in the operating theater, obviously for hygiene reasons, because that wire is going to always stay in the skull. It is introduced in the subcutaneous tissue, just over the course of occipital nerve under X-ray guidance. And then we tunnel it and connect with an intermittent portion, what we call as extension wire, which comes out and it's connected to an external device with which we test the stimulation. We make sure it is in the right target. And then if it is satisfactory, we tunnel it under the skin and connect it to a very small implantable pulse generator, which is implanted below the clavicle. The cost of the therapy, I would say, would come to the tune of about 5 to 6 lakhs. Because these devices, again, are Medtronic devices, only available in India at the moment, only from US. And they are, in fact, even today in the world, the entire world, they are only manufactured in US. We don't have any other country which makes these devices. Definitely not India. So if in future we can have a make in India device, I think the cost can significantly come down. But at the moment, that is the hardware cost. And it's a very sophisticated IPG, which is almost like cardiac pacemakers with a software inside. And that is supposed to work for almost 9 to 10 years. So
That's good.
Okay. But it can kind of, I would say revolutionize the life of a patient. The case example which I gave, he was a businessman, and just 1 year down the line after the implant, now he's saying, I don't even need to use the battery on a constant basis. So his battery is going to last forever. And he says, I just use it once in 3 months, doctor. The moment I feel that my headache is increasing, I just start the device and I get immediate control. Like you must have seen patient taking sumatriptan and all these triptans to abort the attack. Instead of that, he is using a non-pharmacological method to abort the attack. And he's on no drugs, no prophylactic drugs, which is really quite a big thing.
Thank you, Dr.
very
Thank you,
madam.
Thank you so much. Thank you for inviting.
Thank you very much, Dr.
Very nice session. Thank you very much,
Wonderful
Dr.
picture.
Doshi, for giving such wonderful, excellent information about the modalities of the various pain management.
Thank you.
Now we'll move to the next speaker. The next speaker is Dr. Rujuta Hadaye. I request our Vice President, Dr. Girish Rajadhyaksha, who has been recently awarded by Navi Mumbai Municipal Corporation for the best warrior during the corona pandemic. Over to Dr. Rajadhyaksha.
Thank you, ma'am. And good morning, everybody. It's great pleasure for me to introduce my very good friend, Dr. Rujuta Hadiye. Rujuta is the professor and head, the Department of Community Medicine at our TN Medical College and Nair Hospital, Mumbai. She has done MBBS and MD from Lokmanya Tilak Hospital, Sion, and a top ranker from Mumbai University at MD in 1993. She has also done Diploma in Public Health and DNB. Dr. Hadiye has secured her Diploma in Hospital Administration from prestigious TISS or Tata Institute of Social Sciences, and she has also done MA in Marathi. Dr. Hadiye has done fellowship from International Center for Eye Health Institute of Ophthalmology, London. Dr. Hadiye has been a UG and PG teacher and has conducted series of lectures, seminars, and workshops on community eye care, HIV/AIDS, communication skills, epidemiology, and research methodology. She was professor at GS Medical College before coming to Nair and also faculty at LTMMC Science. She was a consultant to Danida and consultant for the World Bank funded Maharashtra Health System Development Project. Dr. Rujuta was appointed as officer on special duty for swine flu in 2009 and for malaria in 2010 in Director ME and MH office. Dr. Hadiye is an avid researcher with various research publications to her credit and has shouldered many responsibilities during COVID pandemic. Dr. Rujuta Hadiye is a recipient of Dr. D.N. Pai Oration and Best Paper Presentation Award at national conferences in Hyderabad and Dehradun. She is a renowned Marathi writer and editor. Today, Dr. Rujuta Hadiye will speak on Our Planet, Our Health, which is the theme of WHO during this year. So without wasting much time, I present before you Dr. Rujuta Hadiye. Thank you.
Thank you, Dr. Girish Rajadhyaksha. And I also thank Dr. Mehta, Dr. Lad, and Dr. Award for inviting me for this wonderful CME. And let me share the screen. Well, today we are going to speak about our planet, our health, which is the theme for the WHO Day this year. So the contents of my speech will be about the health, the World Health Day, what is the aim of it, the theme, aim, and focus, the estimates that WHO is talking about, environmental problems affecting the human health today, measures to be adopted in order to save the environment, the planet, the human race, and live a healthy and productive life. And we'll end with some take-home messages. Health is a state.
The screen is not visible.
Oh, well.
Please share your screen.
One second.
Piyush, are you there?
One second.
Can you help? Can you help?
Yes, I'm here, sir.
My screen is not visible.
Ma'am, do you need help to share
One
the screen?
second, I'll just press. Share screen? Yeah. Share. Is it visible now?
Not yet, ma'am. Yeah, we can see now.
Okay. Okay. Thank you. Yeah. So we'll talk about yeah. So as we all understand, health is a state of complete physical, mental, social well-being, and not merely an absence of disease or infirmity. And it includes the ability to lead a socially and economically productive life. Now, there are various dimensions of health. So different dimensions of health interact with each other and play an important role in the promotion and maintenance of good health of each and every human being in this world, and any imbalances associated with each one of the factors causes ill health or disease. So they include the environmental, physical, social, vocational, intellectual, financial, emotional, and spiritual dimensions. Now, every year on 7th April, we observe this day as a World Health Day to mark the anniversary of the foundation of the World Health Organization which was established on 7th April 1948. We have been observing this day from the year 1950. WHO Day is a global health awareness day that brings our attention to a specific health topic that concerns people all over the world, with every year following a different theme. So what are the aims of the World Health Day? First, to improve the understanding of universal health coverage and the importance of primary healthcare as its foundation, to spur action from individuals, policymakers, and healthcare workers to make universal healthcare a reality for all. Everyone should have the information and services they need to take care of their own health and the health of their families. Skilled health workers providing quality, people-centered care, and policymakers committed to investing in primary health care. So this year, World Health Day, the theme is Our Planet, Our Health, Clean Our Air, Water, Food, and Healthier Tomorrow. So the aim is to direct global attention towards the well-being of our planet and the humans living on it. The focus is on global attention on urgent actions needed to keep humans and the planet healthy and foster a movement to create societies focused on well-being, also interconnectedness between our planet and our health. WHO estimates that more than 13 million deaths around the world each year happen due to the avoidable environmental causes. Air pollution alone kills an estimated 7 million people worldwide each year. 13 people die every minute due to lung cancer, heart disease, and stroke, which can be traced back to air pollution. 9 out of 10 people breathe air containing high levels of pollutants. Between 2030 to 2050, climate change is expected to cause approximately 250,000 additional deaths each year from malnutrition, malaria, diarrhea, and heat stress. 829,000 people die from diarrheal diseases every year caused by polluted water and poor sanitation. 2 billion people don't have access to safe drinking water. 3.6 billion people around the world don't have access to safe toilets. Rising temperature and floods caused due to climate change will put 2 billion people at risk of dengue. Tobacco kills more than 8 million people every year and is highly addictive. 600 million trees are chopped down to make 6 trillion cigarettes every year, decreasing the clean air we breathe. Direct damage caused to health due to climate change is estimated to be between 2 to 4 billion US dollars every year by 2030. So there are different environmental problems affecting human health today, like climate change, and we all are aware about the greenhouse effect and global warming, deforestation, air pollution, water pollution, food contamination, and hazardous waste generation, including radiological, biomedical, and e-waste. The change of climate attributed to directly or indirectly to due to human activities that alter the composition of the global atmosphere, and that is in addition to natural climate variability observed over comparable time periods. That is what we call as climate change or climate crisis. What are the causes? There are natural causes like volcanic eruptions, differences in solar irradiation, variations and tilt in the orbit of Earth, variations in sea levels. There are anthropogenic causes like agriculture, deforestation, construction of water reservoirs, urbanization, mining, land draining, transportation, industrial processes, petrochemical, mineral and food processing, population growth, etc. So there are a variety of mechanisms like human activities increase greenhouse gases like methane, carbon dioxide, nitrous oxide, etc. Greenhouse effect increases the atmospheric temperature, warming of oceans, melting of ice caps, rise in sea level, changes in rain patterns, natural calamities like floods, tornadoes, heat waves, famines and droughts, cyclones, etc. And there is a huge health impact. So there are weather-related illnesses like heat hyperpyrexia, heat exhaustion, stroke, dehydration, syncope, hypothermia, frostbite, range foot, etc. Vector-borne diseases like alteration in rainfall causes alteration in temperature and humidity, and this further affects the dynamics of vector population, causing diseases like malaria, dengue, filariasis, chikungunya, Japanese encephalitis, etc. So I'm sure you are familiar with this effect of this greenhouse effect and how it causes global warming, the contribution of CFCs and haloalkanes and methane and carbon dioxide, nitrous oxide to it. Then there are mental illnesses. What happens is that the changes in weather and more natural calamities, which cause socioeconomic disruption, leads to mental illnesses like stress, anxiety, and depression. Nutritional deficiencies. So extreme weather conditions affect food production, leading to malnutrition and micronutrient deficiencies. Then there are foodborne diseases. High temperature causes growth of salmonella and other bacteria, leading to food poisoning and acute diarrheal diseases. Increased natural calamities also lead to increased rate of accidents and other trauma. There are skin diseases because of increased UV radiations. So ultraviolet rays lead to cancer in skin, sunburn, dermatitis. Then there are ophthalmic diseases like photoconjunctivitis, photokeratitis, corneal and conjunctival cancer, cataract, retinopathy, etc. Then about deforestation, land degradation in arid, semi-arid and subhumid areas resulting from various factors, including climatic variation and human activities. So the causes of it are shifting cultivation, like farmers cut down the trees or burn them and start agriculture and then shift to other places where the soil becomes, when the soil becomes infertile. It happens very commonly with the tobacco farming also. Commercial logging, like cutting of trees for timber and wood, mining and dams, overgrazing by animals, forest fires, government resettlement programs for landless farmers, population explosion. And what happens due to deforestation? So there is soil erosion, expansion of deserts, decreased rainfall and droughts, loss of fertile land leading to decreased food productivity, regional and global climatic change, warmer climate and global warming, loss of biodiversity and economic losses, loss of medicinal plants, and changing in living habits, like indigenous people are forced to live a new life. So biodiversity gets lost. There's a coastal pollution. There is a habitat loss for wild animals. Ocean acidification takes place. The pH goes down. And there is air pollution. So presence of molecules of chemical or biological origin in the air in levels that pose a risk to health and environment. So different sources of air pollution like exhaust fumes from vehicles, industrial processes, emission from burning of fossil fuels, then tobacco smoke, rapid development like construction activities worsen by decrease in green cover, forest fires, burning of vegetation, and use of wood chullas, which are the traditional chullas in still many parts of the country. So these are the variety of sources, and there is outdoor air pollution, which affects the urban and rural areas, and it is caused by multiple factors like industry and energy supply, dust, agricultural practices, waste management issues. And so what are the health effects of air pollution? So there are respiratory diseases like COPD, pneumonia, asthma, tuberculosis, and cardiovascular diseases like arrhythmia, hypertension, myocardial infarction, stroke, atherosclerosis, and thrombosis. There are effects on pregnancies like impaired fetal growth, low birth weight, and stillbirths, etc. Then there are carcinogenic effects like carcinoma of lung, nasopharynx, larynx, bladder, etc. Then water pollution. So contamination of water bodies with toxic chemicals, radiological and biological agents in quantities that exceed what is naturally found in water and may pose a threat to human health and environment. So there are different sources of water pollution like industrial effluents with chemical and radiological pollutants discharged in water bodies, agriculture residues of fertilizers, pesticides, and insecticides pollute ground and surface water, Then there is human waste through open air defecation, leakage, and discharge into water, drinking water reservoirs. So there are a variety of sources of water pollution like oil spills, abandoned mines, combustion due to cars, residential buildings, then septic tanks, sewage treatment facilities, all leaving the polluted pollutants into the water. Then there is mariculture, sludge, atmospheric deposition, landfills, factories, livestock, farm, and so many other sources. So that is how the water gets polluted, and variety of diseases caused due to water pollution, like the waterborne diseases, diarrheal diseases, hepatitis A, cholera, typhoid, guinea worm. Then water wash, poor personal hygiene, diarrhea, again, typhoid, tacoma, scabies. Then there are water-based diseases like intermediate host dwellings in water, schistosomiasis. Then water-related, that is vectors breeding in water. So filariasis, malaria, dengue, chikungunya, etc. And there are effects on human health.
Yeah, sir, right, Lilina.
Diarrheal diseases, vomiting, typhoid, diphtheria, then hepatitis, kidney damage, nerve disorders, and skin lesions. So then there are food pollution and contamination, the presence of physical, chemical, biological matter in the food and food environment. Sources of food contamination include physical sources like air, glass, paper, plastic, flies, product droppings, scabs, etc. Then there are chemicals like pesticides, freezer, refrigerants, food additives, chemicals from clinical cleaning products. Then there are hormones, drugs, etc. And the most common ones are biological, so bacteria, fungi, viruses, and parasites. Variety of diseases caused due to food contamination like salmonellosis, shigellosis, food poisoning, typhoid, cholera, hepatitis A. Variety of cancers like stomach, colon, rectum, pancreas, liver, worm infestation, ascariasis, hookworm disease, etc. Then diabetes mellitus, hypertension, obesity, unhealthy food with high fat and high salt content, which we are consuming every day. Also, there is the issue of hazardous waste generation, a waste with properties that make it dangerous or capable of having a harmful effect on human health or environment. And what are the sources? Our very own hospitals, clinics, and dispensaries generating a lot of biomedical waste, industries, so waste oils, hydrocarbons, emulsions, adhesives, heavy metals, radioactive compounds, agriculture like fertilizers, pesticides, and insecticides. And from IT sector, we have a huge amount of e-waste coming in the forms of used and thrown computers, digital devices, etc. So heaps and heaps of waste are getting generated each day. And what are the effects on health? Mass, life, and material damage, disability, death, fire, explosion, air, water, and soil pollution, increased bioaccumulation leading to irreversible health risks. There are genetic disorders, variety of cancers like blood cancer, lung cancer, bladder cancer, hepatitis B, C, HIV, syphilis through biomedical waste. So there are variety of actions which are recommended by WHO to protect our planet and our health. And there are the simple measures like bike more, drive less, reduce, reuse, recycle, choose sustainable, then educate, volunteer in variety of activities, conserve water, shop wisely, don't send chemicals into our waterways. So what can we do at global level? So the government should share their stories of our planet, our health, curtail the phenomenon of global warming through conventions, international regulations and policies, promote equal and universal access to healthcare resources, promote research in the field of advanced scientific technology, increase investment in the field of public health, targets to reduce emission and conserve biodiversity, build state-of-art public health system across the globe, and avoid widening health inequalities. What can the governments do? Prioritize long-term human well-being and ecological stability in all decision-making, prioritize well-being in all businesses, organizations, social and ecological goals. You might have read about Zerodha. Yesterday, they have given some incentive for reducing the body mass index to less than 25 to their employees. Legislative actions and corporate reform to break the cycles of environmental destruction of the planet, stop fossil fuel exploration, keep fossil fuels in the ground, and implement policies on clear energy production and use wind and solar energy, stop fossil fuel subsidies and reinvest them in public health, tax and penalize polluters, incentivize carbon reduction. So,
Madam, you're not audible. Please unmute yourself.
okay. Hello, am I audible?
Yeah.
Yeah.
Okay. Could you hear my last slide?
Yeah, we are seeing it.
Yeah. Okay.
You can see the slide.
Yeah. No, I think no, my slide is not moving.
Oh.
Okay. Then implement the World Health Organization air quality guidelines, electrify healthcare facilities with renewable energies like wind and solar energy, reduce air pollution levels to reduce burden of stroke, lung diseases, lung cancer, respiratory diseases, tax highly processed foods and beverages which are high in salt, sugars, and unhealthy fats, implement policies to reduce food wastage, repurpose agricultural subsidies for sustainable and healthy food production, build cities with green spaces which promote physical activity and mental health, build climate resilient health systems, protect the existing forest cover by making legislation, demarcation of boundaries, prohibiting human encroachment in these areas, and penal action on violators. Create smoke-free cities, tax tobacco as it pollutes the planets and our lungs, devise policies on waste and plastic reduction, integrate mental health and psychosocial support with climate action and policies to better prepare for and respond to the climate crisis, work with community leaders to mitigate and adopt measures of climate change and support initiatives led by communities at local level. Then there are recommendations for corporations, switch off lights after working hours, support teleworking wherever possible, remove highly processed and packaged foods from the workplaces, reduce greenhouse gas emissions from your activities, protect, promote, and support breastfeeding as it is healthy and sustainable for babies, ensure safe water is accessible for workers. So these are some of the pictures that WHO has spread and disseminated everywhere. So promote breastfeeding and the measures that I told you. So health workers and health facilities support efforts to reduce healthcare waste, provide sustainably grown local foods and ensure healthy food choices by reducing sodas and highly processed and packaged food in health facilities, decarbonize health facilities, identify opportunities to save energy, ensure clean water at health facilities, support purchase of environment-friendly products that are easily recyclable and reusable, advocate for health to be at the center of the climate change policies, aid transition to a sustainable, fairer, resilient, and healthier world. Then the city mayors, what can they do? Promote energy efficient buildings, engage low carbon public transport like CNG buses, electric trains, build new bike lanes and footpaths, protect biodiversity and create new parks and gardens, switch to renewable energy for municipal operations, ensure low-income households and healthcare facilities have access to clean, affordable energy, partner with local business community to support sustainability, regulate the marketing of unhealthy foods and beverages in public spaces. Okay, then of course tree plantations using solar systems, and at individual levels, what can we do? So we have to raise our voice and demand climate actions to protect our health, take action, inspire others, walk, pedal at least one day a week to work, choose public transport, change to a renewable energy provider, turn off lights when not in room, don't heat your room about 21.5 degrees Celsius, buy fresh groceries from local producers, avoid processed foods and beverages, stop consuming tobacco as it is killer and a polluter, use sanitary toilets and avoid open air defecation, maintain hand hygiene, buy less plastic, use recyclable grocery bag, use only purified drinking water for consumption. So these are some of the take-home points. We have only one planet and our health depends on it, just like its health depends on us. We need it and it needs us. And for this, we need to reimagine our health, our society, our economy, and our world. Now, mostly we believe that, like Sir Dr. Mehta said in the beginning, that we believe that we have conquered the nature. Now, what I believe, see, from ancient times, we have been told that our body is formed of Pancha Mahabhutas, that is Prithvi, Apa, Teja, Vayu, and Akash. Now, this particular viewpoint makes us believe, or actually that is the truth of life, that we are very much a part of nature, part of climate. What has happened is that we have dissociated ourselves from the nature, and we have started over a period of time believing that we and nature are different. We have to conquer it, or we have to manage it, and we have to live it as a master of it. None of this is true. We are very much a part of nature, and once we start believing it, we'll start respecting it, preserving it, protecting it, because that is the only way that we are going to protect our own species and the other species on the earth. And that is why the message that I will like to give on this particular day is that when we talk about our planet, our health, remember that we cannot be separate from our nature, our planet. And once we believe that, we will take these steps, which are simple steps, and they will help us achieve a big task. Thank you so much. And
thank you very much, madam. You had covered almost each and every aspect of for the environmental pollutions and all these things. And now the people also understands about the environment, and they also tried, but it is the main thing is a government job. They have to be strict. Educated people can understand about the health and everything, about the environment and everything. And you had covered each and every aspect of these health pollutions. Very nicely talked and everything. President sir, any question from the audience?
Dr. Awad, any questions in the question box?
No, there are no questions in the question box.
Okay. Yeah, so madam was also trying to stress that even individually we all should be very conscious of our health and preserving nature. That is more important. I think the message is taken home. Thank you, madam, for an excellent lecture.
Thank you
so much.
Madam?
Yes, sir. Yes, ma'am. Thank you.
Thank you so much.
Thanks, Xavier.
Thank you, madam. It was really a wonderful lecture. You gave all the, essential, whatever points you have to cover. You have covered all the points. And you've given justice to the topic. And it is basically, it's a theme of not only WHO, but it is a theme of this today's program, Our Health, Our Planet. And you really did a very good job. Thank you very much.
Information is very important. Information is very important.
Shall we move for the next speaker?
Yes.
So now the next speaker is Dr. Shantanu Sen. I request IMA CGP member Dr. Kashyap Dakshini to introduce Dr. Shantanu Sen. Over to Dr. Dakshini Kashyap.
Good afternoon, friends. Dr. Shantanu Sen is a pediatrician, pediatric hematologist, and oncologist at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He completed his DNB from Kokilaben Hospital. He's a member of the Royal College of Pediatrics and Child Health, MRCPCH, from Royal College of Pediatrics and Child Health, London, and FRCP from Royal College of Surgeons of Edinburgh, UK. He has worked in world-renowned cancer centers such as Royal Marsden Hospital in London and Royal Victoria Infirmary in Newcastle, and has an overall experience of 29 years. He's an experienced stem cell transplanter and the only internationally accredited BMT unit inspector in India. His expertise lies in leukemia and lymphoma, brain tumors, neuroblastoma, and other pediatric tumors and bone marrow transplantation. Dr. Sen is a teacher and examiner for the Royal College of Pediatrics, UK. He has presented numerous publications and has been an invited faculty to various national and international conferences. Today, he will speak on hematological disorders, treatment, and complications. Welcome, Dr. Sen.
Thank you so very much for that very kind introduction. Just a small comment. I haven't done my DNB from Kokilaben. I finished my DNB ages and ages ago. I've been teaching DNB at the hospital for the last 10 years. But thank you so much. Thank you so much for inviting me. And it's a privilege to be, and it's a task to follow Dr. Rujuta Hadaya with this wonderful presentation that is so topical, talking about our planet and how we need to save it. And seriously, madam, inspiring talk. I feel privileged enough to have the honor to following you on this presentation. I'll continue with my presentation. Let me just see if I can share my screen with you all. Just give me 1 second. And yeah, I'm hoping I'm visible and my screen is being seen and you all can hear me. Yeah, hopefully I can. Okay, so please stop me at any point if you can't hear me or if there's a technological problem. So what I want to do, and it's a task indeed, to take about 20-25 minutes to talk about what we do, what I do at Kokilaben Ambani Hospital, which is basically looking at curing patients with various hematological disorders. Right. So I will talk a bit about the blood disorders that present with bone marrow failure, which is basically thalassemia, sickle cell anemia, sickle cell disease, aplastic anemia, and then move on a little bit to the common blood malignancies, which is leukemia and lymphoma, talk a little bit about ALL, AML, and the lymphomas Hodgkin's and non-Hodgkin's. And the kind of theme in all of these diseases is that in almost each and every disorder, now we can actually take our patient towards a long-term cure by using a stem cell transplant. So if we talk about which are the blood disorders, the hematological disorders that can be treated with a bone marrow transplant, there are of course the hematological diseases that present with a marrow failure. This is thalassemia, aplastic anemia, sickle cell disease. There's also the hematological malignancies we talked about. But besides this, we can also actually cure patients who present to us with various immunodeficiencies. And that's not part of my lecture or part of my discussion today. But to be honest, in most of the immunodeficiencies that we see in children and in many adults, the only cure for many of these is only with a transplant. That literally is only cure. It's sorry.
Can we increase the volume because your voice is less audible?
Okay, give me 1 second. Let me just see if I can put in a mic. Is this better?
Yes.
Okay, so as I was saying that besides the blood disorders and the immunodeficiencies which I talked about, the other big diseases that we now treat with a transplant are metabolic disorders. And many of these inborn errors of metabolism that plague young kids can be very effectively treated by a transplant. But that's a discussion for another day. Today we just limit ourselves to the commoner diseases that we treat with a transplant, which is sickle cells, thalassemia, aplastic. So, talking about thalassemia, this is basics. We know that it's a disorder, it's an inherited disorder because of a genetic mutation. And it happens when one of the parents, or rather both parents, have one copy of a defective gene. So, it's the unfortunate child who inherits both copies of the defective gene from both parents that lands up with the disease. It's really common in Southeast Asia, and India falls into what we call plumb in the middle of a thalassemia belt, which means that every year we have more than 10,000 children that are still born in India with thalassemia major. That's a massive figure, and we hope to do something to stop it, and that can be only done if we carry on screening patients, screening normal population, college students, office workers before marriage, and send the message that this is a disease that can be prevented as long as you test yourself before it. How does it present? Usually it's a disease that presents in the first year of life, more often around about 4 to 6 months. And the usual presentation is that you have these kids that are feeling a little bit tired, they don't feed well, and that's when if you do a GP or a doctor would do a blood test, found that the patient has very severe anemia. Later on, the other symptoms come in, which are usually the symptoms of iron overload, such as chronic fatigue, liver disease, heart problems, joint problems. Then you have endocrine problems that come in. They end up with something called bronze diabetes, and then basically usual life expectancy for a child who goes into adulthood with thalassemia is not much more than 30 years, to be honest. Diagnosis, you can do a blood count, but basically it needs a hemoglobin electrophoresis to actually find what the diagnosis, confirm the diagnosis. But nowadays, we can actually do genetic tests to identify the specific gene that's defective that has caused the thalassemia. And actually, it's quite important to do the genetic tests in an individual patient, especially if they want to go in to have another child, because then for the next child, we can look at the same genetic defect, whether it's present in by doing a chorionic villus biopsy at 10 weeks, and we can say that that's a pregnancy that should not be carried to term, and we can counsel pair patients appropriately. How do we treat? We usually, it's a blood transfusion is the only way we can carry on saving the patients, give them blood every 2 to 4 weeks. Without it, they will become severely anemic and die. And then comes the problems of transfusion, which means that you need to remove the excess iron by chelation therapy, and lots of chelation agents are there. But if we talk about a cure, it's only a stem cell transplant that can cure a child, which actually replaces the defective stem cells by taking some healthy stem cells from a donor. So what's new? So traditionally, when we do a transplant, we always actually had to look for a fully matched 10 out of 10. A 10 out of 10 indicates that we have a sibling, a brother or sister who's genetically identical to the patient. And that happens only in 5% of our cases. If we don't have a sibling, then we can look for an unrelated donor, and there are bone marrow transplant registries that are there. But that also, the chances of finding an unrelated donor is really to the order of 3 to 5%. So how have we moved forward? So nowadays we can actually do a transplant and cure a patient by taking cells from a family donor who's only 50% match, which means a father, mother, uncle, aunt. Anybody who's only 50% match to the patient can actually be a donor, and we can cure a patient that way. There is gene therapy that's on the horizon right now, and we are also involved in that, and we are hoping it will come in. There are problems with it. I mean, besides the obvious problem of cost, because even now gene therapy is costing us anywhere between 50 lakhs to 90 lakhs. The question is that it still is not yet here, so still now we have to depend upon a transplant. And there are various new drugs that are on the horizon that helps transplant patients, helps thalassemia patients lead a better quality of life. what have we as an institute and personally our unit has done to alleviate the suffering of these patients. So this map kind of shows where we have traveled all across Maharashtra, Gujarat, Madhya Pradesh, as far as Bihar, more now in Jharkhand, Chhattisgarh we have gone. And there we have actually done a lot of camps to see these patients, do a lot of counseling, screened families to see who are a match, and then identified these families. And then we actually counsel them to talk to them about how we can actually do a transplant to cure their children. And this is what we are now doing, where the transplant is actually done free of cost if a fully matched patient, if a matched donor is available. And this is with our various tie-ups, and our latest one is with Coal India, and there are other registries through which we raise funds so that the families themselves are not at a financial disadvantage. So it's not just the well-to-do patients who can access our services and get cured. It's also the auto rickshaw driver in Borivali or the vegetable seller in Chhattisgarh who can come to us and we can cure them. And this is because the cost of BMT is significant. If we look at the cost in US, it's really out of context for anybody else. But even for India, the cost about 8 to 12 lakhs or 15 to 20 lakhs for an unrelated donor is significant. And this is where we have tied up with a lot of our various non-government organizations. Coal India, I talked about. We have a lot of CSR funds from our hospital crowdfunding, which means that we've managed to save a lot of patients, a lot of pediatric cases, taken them to a cure with a BMT. Talking about sickle cell disease, it's an inherited disorder in which the shape of the red cell is altered, which means that during any kind of hypoxic conditions, this C-shaped cell gets stiff, gets sticky, it clusters together and creates a blockage in the blood vessels, which means that the life cell of these cells are very small and these patients get various problems. The inheritance is very similar to thalassemia, which is that if you have two parents with the sickle cell trait, then you would have one patient who inherits both copies would have the disease. And there are various subtypes. You have the sickle cell SS, the SC, and the sickle cell beta. The SS subtypes are the most severe. They present with severe chronic anemia and they really have a terrible life. You also can inherit one copy of a sickle cell gene from a parent and one copy of thalassemia gene from a parent. And this patients also present very early on with severe anemia. The symptoms are anemia, painful crisis, you can get chest symptoms, bacterial infections, etc. But basically the new thing that has come through, that if you have a patient with sickle cell disease, it's really important to put them all on penicillin till 5 years of age. I accept that penicillin is not easily available, so what we suggest is put your patient on augmentin, amoxicillin at least till that age. You need to make sure that we give the patients sickle cell specific vaccinations, which means that all our capsular vaccines are a must, and we have to be very careful for any temperature and sign of infection. And that is because, and this is not something that has been very well appreciated or recognized in the past, that sickle cell disease patients, when they have a fever, they can get sick and toxic really quickly and they might just pass away before they even go to a hospital. And if I speak to my colleagues in the tribal areas or even in Dahanu, where there are a lot of sickle cell patients, their usual story back from them is the sickle cell disease patients, they get a fever, and if you don't put them in a hospital on the same day, they die. And so it's really important to maintain that vigilance with any patient with a fever. Hydroxyurea is absolutely essential, and of course we have to give transfusions and give chelation. I'm just going to go over that and say what can we do for a transplant. So the best transplant outcome is of course that if you have a sibling, a brother or a sister who is compatible, but like I said for thalassemia, we can safely use a family donor also to achieve a cure in these patients. And this is what we have done a number of our patients. Also, we now recognize that sickle cell disease patients are at risk of stroke, sudden death, all of a sudden. So now what we recommend is that all of these patients should be offered a BMT as soon as possible. And again, we have been doing a lot of camps in the tribal areas to identify these patients, to screen them. We do HLA camps. We work with the local government to guide patients towards a cure. And similarly to thalassemia, we offer a transplant program to these patients at almost zero cost to them. In fact, with our latest efforts in order to kind of reach out to these patients, what we have done, we have actually taken over a couple of flats in the area close to the hospital where these patients can come and stay when they have the treatment, and that's also at zero cost to them. Talking a little bit about aplastic anemia, you basically have a marrow that is not producing enough cells, which means that you have decreased hemoglobin, increased risk of bleeding because you don't have platelets and you don't have neutrophils, so which means you're at increased risk of infections. The cause for most cases, in many cases is unknown, but in about 80% cases you can have it secondary to various medicines, etc. And we can classify it into severe or very severe depending upon what the neutrophil count is. Usual symptoms that these patients will present it with severe anemia, they might present with fatigue and paleness if they have a low neutrophil count, fever, infections, and the various other problems you can have. The diagnosis is basically when you do a CBC, we see that all three cell counts are very low. HB is low, white cells are low, platelets are low, and that should kind of push you towards thinking, am I dealing with a patient with an aplastic anemia? The confirmatory diagnosis is by a bone marrow biopsy, by a bone marrow biopsy, but we can of course confirm by doing a genetic test. There are a couple of therapies that are available for aplastic anemia patients. First is medical therapy, which is what we call immunosuppressive therapy, and there are a combination of ATG and cyclosporin is used, and there's now a new drug called L-thrombopoietin agonist, which is added on to this together with steroids to have good outcome. And second is using a stem cell transplant. There are some guidelines which talks about which of the patients should go for a transplant first and which should be treated medically. And basically, if you have a severe aplastic anemia patient and you're a young patient with a matched sibling, you must be offered a transplant. If there are no matched sibling, then the usual recommendation is that we try medical therapy, and if we find that there has been no response, then we would offer a transplant to these patients. What has been recognized is that the outcomes with an immunosuppressive therapy seems to be worse in India than it is internationally. Whereas outside India, they talk about outcomes of 80%. In India, we see only 60% of our patients respond to that. We have transplanted a number of patients with aplastic anemia over the last 4 years. And in fact, what we have been doing recently is transplanting and using a half match donor to try and quickly take these patients to a transplant and cure them before they have had too many blood transfusions. And that's because the more transfusions they have, the more exposed they become to various other antigens. The more difficult it is for us to carry out a transplant, their outcomes are also worse than before. Talking about blood malignancies, I'm just going to talk a little bit about leukemias and lymphomas, and these are the common things that we watch out for to see if they are presenting with fever, night sweats, malaise, etc. And this is, again, if you think about it, it's because the marrow has been taken over by abnormal cells, which means that you get lots of infections. If you have swollen lymph nodes because the malignant cells are in the nodes, that's what would happen. So how do we treat? We usually treat them with chemotherapy in a phase called remission induction, then consolidation, maintenance, and prophylaxis. So I'll quickly talk a little bit about ALL before I'll move on to transplants. So in ALL, basically, the marrow is taken over by these malignant cells, and if you don't treat them aggressively, outcome is really, there's no outcome to these patients. We see very increased incidence in young children, and these are the children that have a very good outcome. So if we look at survival, if I see a young child below the age of 6 or 8 with ALL, I can turn around to the parents and say that this is possibly the worst thing that you've ever faced, and this is the worst news any parent would ever face. but my chances of achieving a cure to that patient is close to 95 to 99 patients. 99%. Adults, it's a different story, because if you have crossed 80 then you have ALL, then the outcomes are not as good as it is in a young child. We talked about the usual signs of symptoms, and these are very similar to a disease where the bone marrow is taken over by malignant cells. And similar way we treat them, we give them remission induction chemotherapy with various combination of drugs, and we carry on with maintenance therapy for up to 3 to 4 years. I'm going to skip over a few slides, and I'm just going to talk a little bit about transplants, what we do. So what is it? What is a hematopoietic stem cell transplant? So a hematopoietic stem cells are the very immature stem cells that are found in the bone marrow, and they are the ones that grow into various other kinds of specialized blood cells. So how do we do a transplant? So the first step is that we need to find a match. We have to ensure that the donor and the recipient cells are compatible, they are matched, and this is done by a process called HLA typing. And how do we do that? We kind of do blood test, or nowadays we do a cheek swab to see how much at a genetic level at this point, which is the chromosome 6, and there is a specific HLA classes that we look at, and we try to match at the HLA A, B, C, DR, DP and DQ, out of which the most important ones in the class A are they should be matched at all three loci A, B and C, and if we have a match at DR and DP, we are happy. If we have a match at DQ level as well, we are extremely happy that we have got a full match. We collect the stem cells either from the bone marrow, the peripheral blood. Umbilical cord stem cells are not much used anymore nowadays, because now we can do a half match transplant. So we mobilize the stem cells, we collect them, we process them, we condition the patients by giving them chemotherapy, reinfuse and wait for engraftment. So as I said, we collect the stem cells either from the peripheral blood or bone marrow, and then the conditioning is that step where we get rid of the patient's disease by giving them high doses of chemotherapy without radiotherapy, infuse the stem cells back to the patients, and then we wait for them to grow in the patients, which is the time it takes for the engraftment to happen, which is anywhere between 2 weeks to 6 weeks. And this is the period that the patient needs to stay in a hospital in a completely sterile environment while waiting for the cells to grow. And at the end of it, we would be able to discharge them with a completely new immune system and hematopoietic stem cell system, really. So what are the factors that impact the success? We need to find the right patient for us to take it on. We need to make sure we give enough medication, chemotherapy to get rid of all the disease that's there. Make sure we give them right number of stem cells and avoid the major complications that plague our specialty, which is graft versus host disease, which really is a huge problem with our patients, but I'm not going to go into there. So I'll talk a little bit about what we have done in the last few years. In thalassemia, we have transplanted more than 41 patients with very good outcomes. And nowadays we are doing more and more transplants for patients who are coming in without a donor, and we are taking the stem cells from either the father or the mother and achieving a cure. We have done something similar for aplastic anemia and as well as for AML patients with very good outcome figures, which we are proud of. Neuroblastoma is a malignant condition that can be treated and cured with an autologous transplant, and we have done a fair number of transplants with very good survival outcomes. Similarly, my adult colleague has been very busy with transplanting myelomas, and we had our share of accolades in the press, and we've managed to actually kind of submit enough papers internationally. But our hospital kind of looks at outcomes, and we are very happy to share that overall over the last few years, we have kind of been at par or better than international outcomes. With that, I want to finish my presentation. I've talked for about 25 minutes, and I'll be happy to take on any questions. Thank you so much.
Thank you very much, sir.
I'm just trying to get rid of this.
There is one question.
Yes, please.
Is there any role of stem cell therapy in the management of sickle cell anemia or thalassemia?
Stem cell therapy, as in we are not talking about a transplant, we are talking about something else.
No, the question is the role of stem cell therapy only.
Yeah, so stem cell therapy, as I understand it as a transplanter, I'm sorry, I haven't managed to find out where am I, so I don't know whether. Let me stop the screens. Yeah, sorry. Okay. So if we talk about stem cell therapy as in a stem cell transplant, then yes, the only therapy that is possible to cure a patient is doing a bone marrow transplant. That is it. So whether we get the stem cells from the bone marrow or the peripheral blood is immaterial, because besides that, there's nothing else that can cure your patient.
Okay.
Can you outline some precautions which these patients need to take? The sickle cell anemia and the thalassemia patients.
Yeah. So sorry. So sickle cell disease, I'll answer first. So because most sickle cell disease patients will be on hydroxyurea. So hydroxyurea is a drug that kind of works by increasing your fetal hemoglobin percentage, but it's also a very potent bone marrow suppressor. So patients on hydroxyurea should have their blood counts checked at least once a month, because sometimes they can get severely cytopenic, and if that is not recognized and they carry on taking the hydroxyurea, their bone marrow can go into suppression. The second is in that phase when they are already somewhat suppressed, if they get an infection, that can very rapidly turn into a fatal outcome. So which is why for the first 5 to 8 years we actually keep the patients on an antibiotic prophylaxis. But even adult sickle cell patients, we tell them that if you have a high fever, don't ignore it. Don't sit at home and take a paracetamol and say that I'll go to my GP after 5 days. It's better for those patients to be aware that they are on a potent drug. Meet up with your doctor as soon as possible. Let him examine you and tell you what you need to do.
Any other question, Dr. Usha?
No. Thank you so much.
It's a pleasure, ma'am.
Any other question from the panel? Ajal?
Thank you so much.
Thank you so much, Dr. Transplant. Shall we move to the next? Thank you so much for giving wonderful information.
Thank you so much.
Blood disorders. Thank you so much. Now the next speaker is Dr. Pallavi Singh. Good afternoon, friends. It's my great privilege to introduce the speaker. Dr. Pallavi Singh is noted specialist in podiatry, health and wellness coaching, fitness and weight training. She is the founder of Stride Fitness and Mobility Clinic since 2014. She was associated with Orthofit, Gold Gym and Talwarkar. She did Bachelor's of Physiotherapy from Indore Institute of Medical Sciences, IMS. She also has a master's certificate in manual therapy. Her skill includes podiatry, musculoskeletal physiotherapy, gait analysis, manual therapy, orthotics, exercise design, exercise prescription, sports biomechanics, and postural assessment. She had received the Maharashtra State Champion Award from the Governor of Maharashtra. Today, she will be speaking on realigning your foundation podiatry overview. Over to Madam Pallavi Singh. Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am, for the warm introduction, and a very good afternoon to all the panelists and delegates. I'm just sharing my screen now.
Yeah.
So, ma'am has already given a very yes. So my company is known with the name of Stride Podiatry. We are having branches in Mumbai, Indore, and Jammu. Coming into podiatry was out of my passion. My mother is a sufferer of diabetic foot and she lost her toe. So that is where I started identifying what is that we are missing, what we do so as to avoid. A lot of advancement now has happened to do diabetic dressing and prevention and all those things. But I still believe there is a lot that we can do together to help identify the root cause of these problems at an early stage, and thereby we can help these kind of a patient from each and every specialty. We have a lot to offer to pediatrics. We have a lot to offer to geriatrics and sports population, then orthopedic cases, diabetic wound, and there's a lot that is there to offer. But today I'll try to cover a few things about foot. When I meet my fellow doctors or physiotherapists, or I go anywhere, I hardly find people who are working intensively in the category of foot or foot modifications kind of work. We are mostly dependent on orthotists and prosthetists to help provide whatever they think is right. But they are not well versed with biomechanics, and sometimes what we are offering to our patients is not sufficient for their day-to-day requirement. Foot is a very beautiful and a complex structure having 26 bones and 2 sesamoid bone if you also include. These small bones are forming 33 joints, and there are more than hundreds of ligaments, muscles, which are holding the structure. It's a beauty the way we can work on soft surfaces, we can work on uneven surfaces, we can run, jog, and do whatever we want. And all this come to us as a natural activity. We never have to think about that I have to lift this muscle for this degree to get to a step or a staircase. So it is such a way that the foot is transferring our body weight from one foot to another without us noticing or taking a support, unless and until in geriatric cases you have some balance issue and then you are taking the help of a stick or a tripod to help you mobilize yourself. The foot is basically divided into 3 parts: hind foot, midfoot, and forefoot. Because the time is less for us to discuss about these things, I'm just gonna pick up one common deformity or a problem that we see on a regular basis with foot. As I just elaborated, that the foot performs a lot of function. The most important that I think is providing us the balance and shock absorption, transferring the ground reaction forces to our body. A well-aligned foot helps preserve your knee and back in a long run. When the alignment is wrong at foot, we will see in the coming slide what would be the impact at other joint. In case of people who are having a loss of the hands and everything, it can substitute to the function of hand also. So we should give more credit to the foot than we usually give. The most important tendon in our body is Achilles, and one of the most commonly injured tendon is also the Achilles. When we are talking about foot deformities, foot pain, a lot of time patients come and say that, oh, I am obese, so that's why I'm having heel pain. But foot is actually a very wonderfully designed and biomechanically stable joint that in normal circumstances, it is capable of taking 3 to 4 times of your body weight when you are walking. The problem happens if the 3-dimensional motion is restricted in the foot due to the malformation of the bones and joints post injury or genetically. Females are more susceptible to foot problems and issues than the male, and part of it is because of the broad pelvis also. So we have to keep that consideration in mind as well. Common problems that we see, which is as a result of biomechanical issues, are hip pain, knee pain, cramps, ankle pain, calluses. Sometimes we'll have people with shin splints. Foot cramps is also common, arch pain, and uncommon symptoms of foot deformities are low back pain and knee pain, which foot is not being given the due credit there. Foot, when we are talking about the movement, there are 2 important movements that the foot perform. One is called as pronation and second is called as supination. So pronation is actually a combination of 3 movements in 3 planes, which is dorsiflexion, abduction, and eversion. The foot rolls inward so that our body can transfer the load from one foot to another. And similarly, when the foot is stabilized and the other leg is taking the step forward, then the same leg will go into supination. So there is a locking and unlocking which helps us in mobile, to provide us mobility to take the next step. The supination is a combination of plantar flexion, adduction, and inversion in the 3 different planes. So foot, first thing we have to keep it in mind, it's a triplanar motion control system. If we don't keep all the 3 planes in consideration and we address only one of the joint part, then we can get into a disadvantage in terms of mobility, pain, and discomfort. So for us, when we are looking into the biomechanical side of issues, we are not bothered about what is pronation, what is supination. What bothers us is overpronation or oversupination. So pronation and supination is common, and that is a normal thing. Nowadays, that word is being commonly used by shoe shops and shoe manufacturers to sell their shoes. They say that it's a pronation controlled shoes or it's a supination controlled shoe. Some of those shoes are good and needed, but most of the time the shoe is just a protection of the foot to provide further shock absorption, but it cannot, if in case there is a overpronation or a flat foot kind of a condition, then the shoe can never be a solution of solving those problems. So if we are looking into overpronation, in common language, people call it as low arch or flat foot. In medical term, we are always addressing it as overpronation when the foot rolls in more than what we normally would appreciate. So the common causes of this thing is genetics. It runs in the family. You will see many patients in the same family with a similar foot alignment, and even the genetics is such that if the father is having the right foot hallux valgus, the son is also having the same kind of fall and the axis of the foot. So genetics play a very important role in this kind of a problem. Our foot is designed for uneven and soft surfaces like sand. Earth is not like too flat and too hard. But for our civilization, we have made hard concrete road and the surfaces are too flat. So when we are walking on it, our foot has to overcompensate for walking. There is no giving in from the surface beneath us. So that's why due to overuse of our ligament for pronation, we develop overpronation issues. Sometimes people are not very well aware about the type of foot that they have, the size that they have. I have seen specifically in female, they assume that the shoe will become loose. So they wear 1 or 2 sizes smaller sandals and opal chappals. In males, the leather shoes, they want a snug feet or a little narrowish and good looking fit onto the foot. So they end up wearing 1 size small most commonly. There are some muscular and postural issues. Many people have spinal deformities. Many people have arthritic changes or ACL or MCL tears in young age. That also change the way they are standing and walking, and thereby the foot deformities can be a secondary complication of such problems. People who are into long-standing activity, runners, marathon runners, ultra runners, they are overusing the foot ligaments, and at one or other point their recoil mechanism start failing. If you're not strengthening and keeping doing right exercises or footwear kind of a check on your feet, you're definitely at a risk of developing overuse, overpronation, secondary or adult acquired flat foot. Age is also a factor, but it is not too big a factor. If we are segregating overpronation of flat foot into 2 different categories, we will see kids more often with overpronation issue. There are certain kids by the age of 7 years, their arches start developing a little better. So nothing is permanent for them till 7 years. Mostly after 7 years, if their arches are not developing, then they are gonna be into a overpronation for lifelong, and these people are more flexible. But on the contrary, if we see a middle-aged person who has never had a flat foot before, was having a normal arch and bone structure, and at the age of 35, 40, they might have sprained or have some other issues and started developing a flat foot. They are mostly adult acquired category, and these are the ones who have more pain complaints. People with congenital flat foot seldom come to you with a pain complaint in the feet. They usually report to the doctors by the age of 40s or 50s for knee pain and back pain related issue. And most of the time, the focus of treatment, unfortunately, is on those two joints, which is giving the pain. But by doing so, we are just addressing the tip of the iceberg rather than solving the whole problem. Certain people have low fat pad also, that is genetic or congenital for them. Those people also have very tight ligaments, and they thereby have more of a foot pain related issues, heel issues, and they are more susceptible for corn and calluses. So that is another category of people. People who have gained substantial weight in a very short period. Sometimes females during pregnancy, or people who went into a hormone disbalance issue and suddenly gain a lot of weight. It don't give the foot muscles enough time to adapt to the increasing weight. If you have just commonly seen a person going to a gym might not be ready to lift 15 kg on day one, but the same person, if it is consistently working out for 3 months to 6 months, can lift up to 100 kg. So same way, the body also adapt to the minor increase in the weight gain. So obesity, sometimes if it is over the period and age related, body can sustain without falling onto the arches. Only the recoil mechanism is something that is little bit affected, but they don't develop a fat foot. But people who suddenly gain are more susceptible for that kind of a problem. In my normal practice, if I say what comes to me more, I see more of a plantar fasciitis or plantar fascinopathy, to be right. That kind of a case is Achilles tendonitis, that is back of the heel pain. Morton's neuroma, that is for people who are wearing high heels, pointed shoes and tight shoes in the toe box, they develop a lot of motor neuroma cases. Many people who are into sports and activity, or who are into open footwear at all the time, they are also at the risk of first ray sprains and turf toes. Shin splint is also common for people who have tibial bowing, high arches, and calf muscle tightness. So shin splints are very common with them. Hallux valgus, or in common terms we call it bunion, it's very common these days. Some of these cases are due to genetics, and some of these cases are due to uses of high heels, ill-sized shoes and footwear. When we are looking into the biomechanical part, and we are doing foot examination, sometimes the patient don't come and tell us that, okay, I have knee pain also, because they think foot is all what we are talking about. But when we are doing thorough examination, we have identified that these kind of people have a lot of chondromalacia patella issues because of the rotation of the knee. The patella bone is not at the groove that it needs to be. So it started over the period of time, the cartilage behind the patella started getting abnormally degeneration happens to them, and then swelling and pain started developing. IT bend syndrome is very common with people having a lot of flat-footedness, and knee arthritis at early age is most commonly 80% of the time associated with flat-footedness. There are certain cases when a person has a fall or a lateral collateral ligament tear for ankle. Then it do happen that sudden over flexibilities develop around the ankle joint, which makes the ankle pronates only on one side and the other side is normal. In such cases, people can develop Lenglen discrepancy as well. And people who are into later stages of arthritis, they sometimes have fixed flexion deformity. And if they get one knee operated and the other knee is still unoperated, then there is a good chance of them developing a leg length discrepancy. Many of these cases, because of the abnormal position of the foot, the pelvis goes into anterior or a posterior palpitated. Instead of making a strong neutral alignment, it goes into anterior or a posterior tilt, and thereby a lot of people will come to you as a PIVD case, back pain, increase in the lumbar lordosis or kyphosis, and forward neck posture. So these are all related because the foot is our foundation. If the foundation is not right, then the spine is very much dependent on the pelvic girdle. So if the pelvic girdle is not in the right position, the spine has to compensate for it. And secondary scoliosis due to LLD is very common in such cases. People will have a lot of discomfort for standing in long queues, and they cannot enjoy their normal life routine like going for a shopping or a holiday or something, because their back keep on hurting. The reason being the weight bearing surface of the foot is not in the proper truss it should be. So when we are talking about this thing, whenever there is a overpronation of your ankle, then to compensate for this overpronation, the tibia bone has to internally rotate, which moves the knee inward. So there is a combination of knock knees with flat foot that is very commonly seen. When these two things are happening, the hip has to internally rotate to compensate for the decrease in the Q angle of the knee joint, and thereby the hip joint goes into a anterior tilt, as I told you. So when this is happening, there will be an increase in the lumbar lordosis. So if you see these two images, the green one is representing a proper dynamics of the body, where the line of gravity and the center of support is everything is in a synchrony. And if this synchrony is being hampered by a little movement of the foot, then the body goes for different symptoms at different points. As a practitioner, if we are trying to solve a shoulder issue and ignore the foot malalignment or LLT, we will not be having a good results. And these kind of people who are having a day-to-day lifestyle with such a discrepancy between the leg and the spinal alignment are very susceptible for falls and injury. So somebody comes to you and they have a repeated history of injuries, and when they are just coined as accident-prone individual, but they are not accident-prone. Their body dynamics is not stable to take load of their body, and that's why they keep on falling, or they bang around the furniture or wall or other people. So if we work on the stability of the foot, they will be having a better center of mass and center of control. This is commonly what you see when you have a very severely overpronated ankle. The midfoot bone, which are supposed to be elevated with the help of the ligaments and the tendons, is not that there in the position, and thereby the navicular and all other medial side structures are being fallen down. When there is such a overpronation, the body has to abduct in the forefoot area to get an angle to walk. One cannot walk with the both feet completely turned inside. So they overcompensate by making the foot go a little wider. Then you will see them walking with a wider stance or tuck feet, or in-toeing also happen for people in certain cases because they overcompensate for the fallen arches. The immediate effect of these things will be the change in the knee structure. People who have a lot of high arch, they have shortening of the fascia in the foot. The muscle is very rigid, and thereby the tibia has to compensate by going outwards rather than coming inwards. So they develop a bow leg deformity. Also, the lateral cartilages are always at a lot of a strain and risk. And these people will come to you for more of a back related issue or spine related issue. They are not having a lot of issue in the knee and the foot to begin with, and they are more injury prone for ankle sprain. If they are into a contact sport, they are coming to you again and again for ankle sprain and injuries, and Achilles tendonitis, posterior heel pain, posterior ankle bursitis, and Haglet deformity. So these are very common with people who are having high arch. Now, high arch people sometimes get passed as good arch people, and then there is a problem. If I oversimplified this thing, there are whenever you are driving a car, you need to have a proper air pressure in all the tires. So if you're talking about bow legs or a high arch person, they are having overinflated tires. And people who are having knock knees are having puncture tires on which they are taking 8,000 to 10,000 steps a day. That is what an average individual walks in a day. Now, if we can identify and treat these cases at an early age, we can avoid a lot of knee surgeries. I have seen one of my patients has got a knee replacement done at the age of 38 years, which I feel is too early. But there was no option left for him, and the doctor has to do what is best for him. But if in future these cases keep on rising, we will be having a lot of early retirements, and people will not be able to enjoy their life past 60. So this is one thing that we have to keep in mind of our patients' longevity in terms of active lifestyle. So this is one of the case where due to overpronation issue, the hip and knee has taken the deformity and the person has developed even the scoliosis in this case. So this is the impact. Now, these kind of a patient, if these orthopedic issues are not taken care of, you can imagine the level of compression that the lung and heart is also taking, and they will have hypertension, diabetes, and other obesity related issues that can be secondary without them knowing that they have a very bad foot alignment. Now, in these cases, if you ask them to go for exercises and walk for 1 hour, it is a very difficult task for them to accomplish. Walking 20 minutes on a back foot is like taking a truck over your feet. So it is very difficult for them to do common activities. So going to a gym or exercising will never be a choice that they will do by themselves. When such cases come, how we should address? Most of the time, I have seen in my practices that doctors don't even ask the patient to remove the shoes. So they hear and they, based on the clinical observation, sometimes the treatment is prescribed to them. But what we can do is, if the person is coming for even the back or the knee, while we are doing the examination of back and the knee, we can include foot examination as a thumb rule, and we can follow a simple principle of look, feel, and move. A lot of peripheral neuropathy issues is visible once you are looking at the coloration and discoloration of the feet. The skin texture and condition of the foot can also give you a lot of insight about the blood circulation towards the periphery, any scar tissue, so that we can know that there is a previous history of operation surgeries or injuries that has disturbed the alignment of the knee and the back when the foot was injured. And we can see for muscle wasting, sometime people who are overusing one leg and not putting load on the affected side will have a decreased dimension at the calf also. We can see if they are using any supportive aids like a stick or a crutch or something, or whether they are prescribed or they are self-using it. So knowing those things are also important for assessing the person further, whether they are a good candidate for realignment issues or not. We can see for the temperature pulse, for palpation of the ankle and the Achilles tendon, for any sign of injury or a break or effusion underneath the muscles if there is any. Then active range of motion, if it is restricted on one side than the other, then it means that either there is a bony block or a muscular block. Then further testing can help us evaluate whether the loss of range of motion is due to active bone injury or a bone deformity, or it is because the tight muscles of calf and other muscles. For that, we can do some biomechanical test, which can be done in non-weight bearing process, which can be done in weight bearing, and then we can do gait analysis, foot posture index as well. Nowadays, there are devices that you can put on your hand and you can check the patient's range of motion, muscle power, and it will give you in a digital format what is the range of motion at each joint of the person. So that can be used to replace goniometry if you don't have much of a time. Foot posture index help us to identify whether the person is on a supination or a pronation side in a quantitative manner. Gait analysis can be done visually, so we can see if anything pops out when a person is normally walking to us or walking away from us. The other thing that we can do is pressure plate analysis or a video gait analysis that can help in identifying the correct angle. So we use all those things in our practice to identify what the person is doing. the new advanced thing that we have is called as AI system. So we put the small sensors on different part of the body, and we make a person stand, walk, jog, jump, run, and we see on a single leg how they are walking, on a two-leg support how they are walking, and all the analysis is digitally given to us with all the graphs and insight that we require, and it becomes easy for us to explain to the patient that what muscles they need to work on, what exercises they should do, and what movement they should be avoiding. It helps in geriatric cases if we want to assess any fall risk, any injury risk, any imbalances issue, and how deep and how problematic they are. We can have a digital proof for that, and that helps in making the patient safer when they are walking. If supportive aids are needed, we give them. We ask them to use proper orthotic insoles and control, and then we give them the exercises to make sure that they are not falling because of muscular imbalance. So this is some setup that we have in which we can make a person stand and walk on a sensor-based treadmill. Once you work on it, it gives us a data of what portion at what site, what phase of your gait cycle, what is the pressure. And then we can compare your different analysis at different points to see whether you're improving or not. So it gives us a digital map to work on with the patient in future once we are doing the insoles and corrections. We also use pressure plate. We also use shockwave therapy to make sure that the patient get the best of the treatment. Now, after doing all this assessment and identifying the issues and problem, it is very important for us to give a solution. Just by knowing what is wrong is not the end of the treatment. So in these cases, because it's biomechanical, any medicine, any surgery can give temporary help and relief. But if the joint and motion is not being controlled proficiently, then the person will keep on having instabilities, fall and injury over a period of time. So after a thorough examination of the structure and the function of the body, we do make customized insoles and orthotics. So we have a system from Europe where we can scan and make a customized insole of a person. Just for a small demo, I don't know whether it is visible for you or not. So these kind of flat insoles are available with us. We put it in a machine which is heated, and then on a patent pillow, the person is stand, and the insole is crafted as per the person's body. So the arch is fully customized for the person. Sometimes a female comes to us and they say that it is not possible for me to wear shoes all the time. How would I be able to counter my pain and discomfort on a day-to-day basis? So apart from insoles, we can give them these kind of footwears which has an inbuilt arch support, and it helps in keeping the heel in the position where the calcaneum is less rotated into inversion and eversion. And by the support at the medial arch, the plantar fascia and the supporting structure of the body, which is not being able to work on its own, started working. So proprioception part is improved by using customized insoles and orthotics. Pain management, apart from these things, are necessary. So for that, we use various physiotherapy modalities in terms of cupping, needling, massage gun, shockwave therapy. They all help in reducing the symptoms of the person and help them to walk normally. Once the posture is corrected, the confidence of the person improves. Many a time they can go back to their life goals. If they want to travel, they can travel. If they want to lose weight, they can lose weight. And this helps in avoiding knee surgeries in cases which is not needed at early age. Sometimes the doctor wants that the person should be able to survive for 2-3 more years, so as a better chance of implants is there. In those cases, if a proper strategy is formed in consult with the doctors and the surgeons, then the results with the patients are tremendous in terms of pain relief and going back to normal routine. Such cases do very well if they do a pre-rehabilitation before the surgery. They start working on the alignment and the other joints which were affected because of the foot is being tackled. Then post knee surgery or knee replacement, these persons respond back to life in a lesser time period rather than after surgery, just sitting in the house. And the only result they were getting before was just the pain relief. So as a practitioner, our goal is always to make a person healthy and make them fit to do normal day-to-day activity with the way they want to do. So that's it from my end. If there is any question, I'll be more than happy to answer.
Thank you, ma'am. It was a very wonderful talk. Madam, can I ask one question?
Yes, ma'am.
Yeah, in a rheumatoid arthritis, if the bones are not involved and only there is a contracture of the tendon and muscles,
yes,
the rheumatologist always asks for the physiotherapy, or they can ask to put a plaster.
Yes. Ma'am, before the deformity is fixed or set, if through podiatry we do customize insoles and orthotics, the results are much better. If before the hammer toe or claw toe can happen, if the foot is being controlled with the medicine side by side, if the foot alignment is being controlled, then the contractures and deformities are far less. And nowadays, there are some modalities in which you can do mobilization for scar tissues and contractures also. So certain release can be done side by side. But what is more important is we might be doing physiotherapy for say half an hour, 1 hour a day. A person might be exercising 1 hour a day. But throughout the day, they are standing, walking, they are doing their normal activities. What controls that normal activity is what is more effective. So that's why if I just give you a insole inside your shoes and you're walking with a normal sport shoes or a formal shoes, then it is taking care of your alignment till your spine and shoulder. So that way it eases off your stress and you can walk better, you can stand better. More the function, lesser the deformities.
Okay. I want to ask one.
Yes, ma'am.
The metatarsalgia on walking,
yeah,
can be due to stiff calf muscles and improper spine alignment and at least improper gait, no?
Ma'am, those are contributing factor, but forefoot metatarsalgia is very common with people who have fallen transfer arch. So we have 3 arches in the foot: medial arch, lateral arch, and the forefoot arch. So if that forefoot bones are dropping because of the weakness of the intrinsic muscles, metatarsalgia is very common. Pointed shoes are more culprit in this kind of a pain, and people with heavy body, obesity, and an anterior pelvic tilt, their weight distribution is more in the forefoot rather than the midfoot and the heel. So they are also very susceptible for metatarsalgia. And they are very susceptible for cons and calluses also.
So in our practice, we get a lot of patients with heel pain, and on X-ray they show calcaneal spur.
Yes, sir.
So if
you take X-ray of asymptomatic people also, you will see calcaneal spur very commonly in the patient. So due to the prolonged stretch and overuse of the plantar fascia, we have extraosseous bone formation or calcification at the attachment of plantar fascia. So if it is not disturbed by foot alignment or an injury or a certain jump, say sometimes what we do is we keep on wearing the shoe which is worn out. If a female is wearing open chappal which is too flat and hard for the feet, the foot don't get the proper shock absorption. And if they have a tight calf muscle and all, it will pull the calcaneum from behind and the plantar fascia is pulling it in the opposite direction. So that Vilnas mechanism is being under stress, and that causes the calcaneum spur to form. If a spur is there, best is to put the calcaneum in a neutral space. Just the normal sleeper, the arch sleeper, helps in putting the calcaneum in a neutral space. Body has a tendency, if I take a pen and I start poking my skin 50 times, 60 times, it might hurt. But if it keep on hurting on the other side, the other area will become numb. So if the spur is there, which is live in the body, but the other area is hardened and stiffened by the constant friction, then the pain will not happen. Such people can have pain only when there is a change in the dynamic, like a sprain or an injury or a tight calf muscle or increase in the body weight or worn out shoes. These are the major factors to have again and again the phases of plantar fasciitis.
How different it is from plantar fasciitis? the pain?
So usually when there is a starting stage, the plantar fascia pain is felt all over the heel. So patient will typically complain when they get up in the morning and put their feet on the ground. It is very painful. After walking 4-5 steps, the pain is reduced. When there is a calcaneum spur formation happen, that is usually after 3 months of the plantar fascia stage, and the patient will typically point you that I get heel pain here. They will have typically the attachment of plantar fascia, that is they are pointing, and if you take an X-ray at that stage, the spur is visible. So it is more focused pain, and the pain is dull aching. It is not sharp shooting. So they are living their day-to-day routine with that spur pain. But plantar fascia is so agonic in terms of the pain that they cannot do normal day-to-day activity, standing for long and walking for every time they are sitting and standing, the pain is there. With calcaneum spur, they will feel pain when they are walking bare feet or early in the morning or late in the evening. But daytime, when they are wearing normal footwear, they will not feel the spur pain. So that is the determination factor for fasciitis and fasciopathy and spur.
But you get plantar fasciitis in the arch also, no?
Yes. So mid-arch foot pain is common. The fascia start getting stretched because of the drop of the naviculum bone. So if someone is having cubitis, या फिर उनको calcaneum spur के पास में कुछ inflammation हुआ है, or other cases if there is a naviculum drop, then these all cases will have supported plantar fasciitis. So if you address the medial arch, then the fasciitis pain is easily taken care of. Usually steroid injections are given in these cases, but it only works temporary because the fascia is rotated and twisted. So जब तक आप उसको untwist नहीं करेंगे, that pain is not gonna go anywhere.
So patients sometimes don't want to take steroid injections.
Most of the time these days, they have read on Google that steroid is bad for health, so they will not want to take it. And even if after giving PRP is also failing in such cases, steroid is also failing in such cases because it's a motion control problem. Every time the person is stepping 8 to 10,000 times, if the ankle is pronating unnaturally inside, then it is gonna injure one or new other part of the body. So how you can counter that with any injection and medicine? Even physiotherapy fails in that case.
But you can do with cold therapy and anti-inflammatory drugs.
It is only gonna address the tip of the iceberg because the bone positioning is like this. So our feet work in a nut and bolt mechanism. If the nut is in this position and the screw is in the opposite direction, there is a mismatch over there. So जब तक आप उसको proper locking में नहीं करेंगे, they will not be able to function. It's a truss. The foot has a triangular weight area support. जहाँ heel रहता है और forefoot में 2 points है, तो वो जब तक triangle में आपका weight bearing नहीं हो रहा है, उस triangle से बाहर है आपको pain होगा ही होगा.
Thank you very much.
Thank you so much.
Thank you, madam. Thank you.
Yeah, thank you so much for giving this wonderful information about this. Nowadays, there are a lot of problems with the foot and ankles, and this is the best you had communicated. Thank you so much, madam.
Thank you, ma'am. Thank you. It's a great honor to present in front of all of you.
Yeah. Now we'll move to the next speaker, Dr. Rajesh Bendre. I request Assistant Secretary, IMA CGP Mumbai Subfaculty Branch, Dr. Kajal Ahuja, to introduce the speaker.
Good afternoon. Dr. Rajesh Bendre is a Chief Pathologist and Lab Head at Newburgh AC Diagnostic Private Limited, Chembur. He completed his MBBS from MGM Medical College, DPV from College of Physicians and Surgeons, Mumbai, MD Pathology from Grand Medical College and JJ Group of Hospital, and DNB Pathology from New Delhi. He did PG Diploma in Clinical Research and Patents from CAHS Matunga, Mumbai. He received immunofluorescence interpretation training from Autoimmune Diagnostic, Lübeck, Germany. He has trained in the management of component blood bank apheresis services and lab management through IIM Kolkata and IIM Indore. Dr. Bendre was previously associated with Jaslok Hospital, Metropolis Healthcare, Piramal Fatke, Wellspring Andheri, Masina Hospital, S.R. Mehta and Kikabai Hospital, King Circle, and Somaya Medical College. He has an overall experience of more than 22 years in clinical chemistry and hematopathology. He is an accomplished NABL CAP assessor as per ISO 15189-2012. His special interest lies in autoimmunity, flow cytometry, hormonal and drug assays by HPLC, LCMS technologies. He has presented numerous publications and has been an invited faculty to various national and international conferences. Today, Dr. Rajesh Bendre will be speaking on lab diagnosis of autoimmune diseases. Over to Dr. Rajesh Bendre.
So very good afternoon, everyone. And thank you for that very kind information and my introduction, madam. And at the outset, I'd like to thank IMA Mumbai to give us this opportunity today to present myself and present some of the thoughts on this topic chosen for today, which is lab diagnosis in autoimmune diseases. So I'd like to share my slide now. Am I audible and the slide visible, ma'am?
Yes, sir.
Yes. Okay. So I would like to begin with this topic and a discussion on this by some conceptual thoughts and points. We all know what we talk about when we say the word autoimmune or autoimmunity. It is nothing else but our own defense system or our own immune system, which is acting against us. And when that happens, that is what we call as autoimmunity. Now, there are two important concepts that we must keep in mind whenever we are discussing autoimmune diseases. So there is a concept which we should remember as autoimmune phenomena. Now, autoimmune phenomena is a concept where as our age advances, every one of us are prone to have autoantibodies. Now, this is a very important point that these are happening as a natural course and as an aging phenomena, that we tend to have autoantibodies. But the difference is that whatever autoantibodies which are developed, the question to be looked into is whether these autoantibodies, are they causing a harm and are they causing a tissue damage? If the answer to that question is yes, then this is a patient who is a sufferer of those autoantibodies, and hence she is having an autoimmune disease and no longer an autoimmune phenomena. So that's a very important point which I want to drive in from this slide. Second important point which I want to drive home is that as you have seen, all of us have seen in our own practices, that these two group of diseases, which is autoimmune phenomena and diseases and allergic disorders, are definitely on the rise if you look at over the past 5 to 8 years. And if we go through literature, what is spoken about is a hygiene hypothesis, which is probably to blame and which is probably the reason that these diseases are seen by us more and more. So it is something which is spoken jokingly sometimes that, you know, our immune system, when it was busy, say a decade ago, fighting with various infections, because infective pathology was always on the rise and always there in the background. So our immunity always was busy fighting various infections. Now that we have taken care of infections in a better way, the hygiene overall, at least in the metropolitan cities and the urban population, has improved. So the immunity actually doesn't have much work to do. And here is where it gets misled. And here it starts rather acting against our own self instead of acting against the non-self. So that is to put it in a very simplistic way. And that is what that hygiene hypothesis is talking about. So to cut the story short, that definitely we have autoimmune diseases on the rise. And I think that's the reason that we have chosen this topic today, to briefly refresh ourselves as to the concepts and the diagnosis for autoimmune disease. Traditionally, autoimmune diseases always have been classified as organ specific, that these are antibodies which target specific organs in our body. And the classical example of that is thyroid. And one of the commonest autoimmune disease which we do come across our practices is autoimmune thyroiditis. Similarly, we do have autoimmune diseases which are systemic. And as you can see in this particular table, that you do have a list of autoimmune diseases which are organ specific and systemic. The one which is a change which has happened recently, which is worth mentioning, is ulcerative colitis or inflammatory bowel disease, as we would put two broad heads as Crohn's disease at one end of the spectrum and ulcerative colitis at the other end of the spectrum. Now, this is today considered as a systemic autoimmune disease, and which in the past was considered as an organ-specific disease. So that is a newer change or a newer concept which has happened. If we look at the etiopathogenesis for an autoimmune disease, it is always spoken about that a person who has some genetic makeup which makes the person prone. So he is at risk genetically to have an autoimmune phenomena and an autoimmune disease. In such an individual, when we have certain environmental factors and any other personal etiopathogenetic factors like infective etiology inclusive, they all when come together in a common host, that is a time that there would be a trigger of an autoimmune phenomena and possibly an autoimmune disease. So it is a multifactorial disease. That's the point which I wanted to make. And there is no one factor, but there are multiple factors involved, including hello. Including the hello.
Disturbing the panelist.
Hello. Hello.
Sir Jitesh, please put on mute.
I cannot say yeah, so I think I'll continue that the approach when we talk about various autoimmune diseases is the first point is a very strong clinical suspicion that we are suspecting an autoimmune disease, and we need to go for a specific test. I think
can you
I would request
on your mobile phone.
Hello.
On mute, please. I request all the panel doctor.
Hello. Hello, may I request?
Jitesh Mehta, can you hear me? Dr. Jitesh Mehta.
Hello.
Hello, yes.
Please put everybody on mute.
Dr. Attar. Dr. Attar, please be muted.
Yeah, thank you, sir. Thank you, sir. So the approach when we talk about for various autoimmune diseases would be the screening test, which we often talk about as an anti-nuclear antibody test, which is our screening test. And this, if it is further taken up further with certain other secondary tests or specific tests, which would categorize the disease in the right way. So that's the common approach which is recommended. And I'm showing you a flow chart, which is what is usually followed. And I will take you through all these various tests, the limitations of the tests, and the recommendations for the test in the subsequent slides. So when we talk about the various tests which are available for diagnosis in a suspected autoimmune disease, we would categorize them into two broad heads. One which is a screening test, and another are the specific autoantibody tests which tell us and point us towards specific reactivities and help us to categorize the patient in a correct autoimmune disorder or a disease. So the commonest screening test which we talk about is an anti-nuclear antibody test or an ANA test. And the testing methodology which is recommended is indirect immunofluorescence, which is the methodology of choice and a recommendation. The other group of tests, which are specific autoantibody reactivity tests, there are various methodologies available here for us to do these tests. And it starts with ELISA or chemiluminescent assays, and we have immunoblot technique. So in the subsequent slide, I would make you aware about the advantages and disadvantages of some of these tests and why these recommendations have come up. So talking about ANA in a very quick and a brief way. Now, ANA is a time-tested test. The history of anti-nuclear antibody as a test goes way back in 1948, as you can see in the slide. But over a period of a millennium now, this test also has undergone a lot of evolution. So in old days, the ANA test, which was done by indirect immunofluorescence, used primate and liver cells or your kidney cells from primate. That is, they were animal substrates which were used. But gone are those days. In today's time, we are using what we call as HEP2 cells or human epithelioma cell lines. And the reason that I am telling you this is that we are testing the patient's serum sample against a substrate which is human only. It is no longer animal source. And hence, the sensitivity and specificity of an anti-nuclear antibody test today has considerably and significantly improved over a period of years. The old test which we spoke about, an LE cell phenomena or an LE cell test, today is an obsolete test, and the screening test recommended is an anti-nuclear antibody with an indirect immunofluorescence methodology. When we do indirect immunofluorescence methodology for an ANA, and just few moments ago, I just began my topic saying that we do have an autoimmune phenomena happening routinely as age advances. So when I say this, it also means that if I randomly do an ANA in a general population, I would get positives. And then these positives will not have any clinical symptomatology if we look at the patients. So how do we address this problem? To address this problem, what has been standardized is what is described as a sample screening dilution. So there have been ample number of studies where they, as you can, I have pulled out one study, which is an Indian study, which was done in 2007, talking about what are the titers that we would get anti-nuclear antibodies in healthy population. So you can see on this Indian study and similar studies done internationally as well, the recommended sample screening dilution today becomes 1 in 80 or 1 in 100. So when I do a test, which is ANA, with a sample screening dilution of 1 in 80 or 1 in 100, the possibility of autoimmune phenomena and the antibodies due to autoimmune phenomena are removed. So now when I give a report of an ANA as positive at a dilution of 1 in 80 or 1 in 100, that is a significant autoantibody which is present, which needs to be further correlated from the clinical symptomatology. So that's the point which I'm trying to make it clarified here. The ANA, once it is positive, the second step what I do in our ANA-IF report is to give you what is the pattern that it is showing me as positive. So we go back to our normal histology of a cell, where we talk about a cell having a nucleus, the cell having a cytoplasm, and each of these have got multiple components within them. So based on this normal histology and the positivity that I am seeing under the indirect immunofluorescence, I call it as various patterns being positive in the cell of an anti-nuclear test. So I may have only nucleus which is positive. So it would be a nuclear pattern which is positive. I may have only cytoplasm which is positive. So it is only cytoplasmic pattern. Or I may have cells which are only dividing cells which are positive. So only it is the mitotic dividing cells which are positive. So these are the three broad patterns which I see under the microscope. And each of these patterns has got its own clinical relevance and significance in terms of its association in specific autoimmune disorder, which is what I will be showing in subsequent slides to you. So this is a small grid, and just to give you a pictorial image of what I see under a microscope when I say that it is a speckled pattern or a homogeneous pattern under indirect immunofluorescence. So that is how I see it under indirect immunofluorescence. And it looks quite beautiful, and it's quite a beautiful world for an indirect immunofluorescence. So I have enumerated in the table various patterns that can be seen under indirect immunofluorescence and what are the target antigens that it depicts and what are the common clinical conditions that it is commonly associated with. So the first one, as you can see, that a homogeneous pattern, an ANA pattern positive, is the one which is most likely directed towards double-stranded DNA or histones, and the commonest association with it is systemic lupus erythematosus, or which is SLE, which is our prototype autoimmune disease. Similarly, when I talk about a nucleolar pattern, this is the one which is targeted against the nucleolar RNA within the nucleus. And this is a pattern which is very, very classical and very, very synonymous with the condition which we call as systemic sclerosis, and so on and so forth. So here, the point which I'm driving is that not only saying that the ANA is positive is enough, but I also need to give you information as to what is the pattern which is that it is showing as positive, because that will point towards a specific autoimmune disease. Are there any studies in the literature which talks about sensitivity and specificity of the association of these various patterns and the autoimmune diseases? The answer to that is yes. And again, you can see various patterns here and the sensitivity specificities. So most of them, as you can see, that the specificity is very, very good. The sensitivity is variable. And amongst them, to highlight specifically, the one which has got the lowest sensitivity is SSB, which is a common antigen associated, autoantibody associated with Sjogren syndrome. So this is one area where ANA, if you are suspecting Sjogren syndrome, SSB is one which has got the lowest sensitivity. That is a point which I'm trying to make here, and one can remember this particular point. In the past, we all must have come across cases, and I'm sure all of you would have come across case where you have had an ANA report as positive, and the commonest pattern where it is given is speckled. And clinically, the patient may not have any signs and symptoms. So there have been a lot of retrospective studies and analysis done today of all these cases where ANA was positive 1+, it was a speckled pattern, but there was no clinical symptomatology to the patient. And in today's newer articles, what has come out is that we need to identify one more additional nuclear pattern. So this is a newer advance. This is a newly identified ANA pattern, which I wanted to discuss and share with you, that apart from what I showed you earlier, the one which is added recently is this DFS70 pattern. And the importance of this pattern and a lab being recognizing it, a lab being reporting it, is the important point is that lot of almost 10 to 12% cases in the past where we did not have a clear answers as to why the ANA is positive, and clinically there is no signs and symptoms. The 10 to 12% of such cases probably belong not to ANA speckled positivity, but they belong to this pattern, which is DFS70. And there is a way to identify it very clearly, which is the nucleus being positive and mitotic cells being positive, both being positive and the nucleus showing the speckled pattern. That is what is DFS70. This pattern is being shown to be associated with non-rheumatic diseases. And the commonest disease often associated is atopic dermatitis. So that's the relevance and clinical importance of knowing this particular pattern and identifying and reporting it as a part of ANA reporting. So those were few thoughts and important points which I thought I'll share with ANA. Proceeding further, talking few points on double-stranded DNA as a test, or dsDNA as a test. Now, dsDNA test also over a period of time has gone through an evolution, and the current recommendation the testing methodology of choice is ELISA. Gives you a semi-quantitative number as positive, negative, and a number or a titer which you can follow as the patient is put on therapy. And the earlier methodologies like RIA or indirect immunofluorescence is no longer recommended. And the reason for that table that the sensitivity and specificity with the newer ELISAs, which is a combination of the dsDNA and the nucleosomal antigen, has considerably improved. So, I just told you a few moments ago that indirect immunofluorescence is the methodology of choice and not the other methods. While in dsDNA, I am clarifying to you, it is ELISA which is the method of choice and not the indirect immunofluorescence. It is slightly reverse when it comes to the testing methodologies for ANA and double stranded DNA. You also must have heard about something called as a single stranded DNA. Yes, we do have antibodies against single stranded DNA as well. But most often these ssDNA antibodies are associated with non-rheumatic conditions and hence not important in terms of our today's discussion as autoimmune diseases. So for autoimmune diseases, for SLE as our prototype disease, the diagnostic hallmark is double-stranded DNA and dsDNA autoantibodies. The third step, which I showed you in the earlier flow chart. So the first screening test was ANA. The second level test was dsDNA antibodies. The third level monospecific antibody testing is what we call as extractable nuclear antigens or ENA testing. The word ENA, as the name given, extractable nuclear antigen, in a simplistic way, if I minus double-stranded DNA from the nucleus, what remains behind in the nucleus is what is called as extractable nuclear antigen. So this is a very large area of huge antigens being present there. And there have been so many studies. And today we have a clear chart as to which particular extractable nuclear antigen is classically associated with which particular disease, which will be there in the subsequent slides for us to discuss further. Here I am showing you a comparison between advantages and disadvantages of ELISA, which is a monospecific ELISA methodology for your ENA screens and ENA testing, and an immunoblot. Now, immunoblot also is a good methodology, but when I compare between the two, there are some antigens where the sensitivity is better, while there are some other antigens where the sensitivity is poor. And that is exactly what I want to share with you, because here is where you might come across a case with a patient report where earlier it was done by ELISA, sometimes it is done by an immunoblot, and we need to know which methodology is better for which particular test. So here is a simplistic chart which I am showing you against various extractable antigens enlisted on the left side and a comparison between the two methodologies. So just 2 points to be highlighted from this entire chart. For SSB, which is an important antigen and autoantibody to be identified for Sjogren's syndrome, immunoblot is a better testing methodology. While ELISA is a lesser sensitive technology compared to immunoblot. But if you look at all other extractable nuclear antigens, like the other example is SCL70, again a very, very important autoantibody for scleroderma as a disease, ELISA is more sensitive than immunoblot. So when we look at various reports of an ANA, dsDNA, and the ENA reports, what is the testing methodology is the point which I am trying to drive across, that we need to keep in mind when we are comparing all these various reports, because this is which will help us, give us the confidence in identifying, in categorizing the patient as to what autoimmune disease he/she belongs to. Having told all this, I want to drive the same points in a more simplistic way by giving you two simple clinical case studies. So here are two simple case studies. So the first case study is a 45-year-old woman who is now complaining of mild arthralgia, in hands, especially the proximal interphalangeal joints, and it is since 9 months. The same patient has given us a history that 1 year ago that the patient had rash, and the rash has responded to topical antibiotics. Since there was a history of joint pains for last 9 months, a ANA test was prescribed, and the ANA came out to be positive at the sample screening dilution titer as 1:80. The patient was further referred to rheumatologist, and further detailed family history was taken, and there was a very strong family history of similar hand osteoarthritis which was present with this patient. So this patient was diagnosed with osteoarthritis and not with an autoimmune disease. The presence of an ANA being positive is probably just an incidental and coincidental finding in this particular clinical setup. Similarly, so what I'm trying to say here is just getting a report of ANA positive is not enough. It needs to be correlated with clinical symptomatology and clinical findings. If both are together, if we are able to find and document the damage or the tissue damage, then yes, it is a disease. Otherwise, we can just keep the patient on follow-up and consider it as an autoimmune phenomena and not as an autoimmune disease. This is a second case of an 18-year-old male who has now come out with weight loss anorexia. Patient has a past history of being treated for acne with minocycline. Now the patient has got synovitis and joint pains in the hands. His CRP, ESR is raised. There is lymphopenia in CBC, and an ANA test done is positive at a titer of 1:640. dsDNA antibodies is also positive. Now, in this case, you have a screening test which is positive ANA at a significant titer of 1:640, and a confirmatory test or a specific test which is dsDNA, which is also positive. So it definitely points towards an autoimmune disease and an autoimmune etiology. The only point here is that we need to incorporate the history provided by the patient to us, which is minocycline. And we know that minocycline is a known drug who can cause what is also called as a drug-induced lupus. So that is another important point that we need to differentiate and keep in mind. What is the drug history that the patient is having? There are certain drugs which can also induce autoimmune phenomena. And once the drug is withdrawn, these patients would come out of that induced autoimmune phenomena. So having said and given you these practical examples, that is my concluding slide, that autoimmune phenomena increases by age and needs to be correlated always with every patient, and a point worth always remembering. There are various testing methodologies which are available for performing ANA, DNA, and ENA tests, and each have their different sensitivities and specificities, and one needs to incorporate that when we are interpreting them. And a weak ANA positive result definitely, I think, has to be strongly clinically correlated. If there are no clinical signs and symptomatologies, it would be worth to follow up this patient after 3 to 4 weeks and see what is happening, whether the titers are increasing, and if required, follow up the patient with monospecific ELISAs or the ENA testing. So the point, as the final point, is that we don't have to treat the serology, but we need to treat the patient. So we need to take everything into consideration before labeling the person as an autoimmune disease. So those were my thoughts and points to share with all of you. Thank you very much, and thank you.
Thank you so much, Dr. Bendre, sir. It was very wonderful information. The topic is very detailed and it is a little bit complicated also, but you managed very well.
So many things are new for us. But good to know that there is a lab which does all these sophisticated tests. Yes.
Sure.
So what is the average cost of such tests when we send a patient?
So the ANA tests, ANA and the dsDNAs are basic tests, and I don't think they are costly. They are less than 1,000 rupees. ENA would be a profile, or an immunoblot will be a profile, which will be slightly on the higher side. But the basic tests, which are our ANA and DNA, are not something which are costly. No.
Blot is better or IFA is better?
So that's what I clarified to you, sir, that both of them have got advantages and disadvantages. The immunoblot, to repeat the point, the immunoblot is good for certain antigens, and they are mainly SSB and SCL70. Immunoblot is very good. But for dsDNA, for SSA and other antigens, we need to go for ELISA. And that is the reason that we do come across cases where across labs, when we compare, if it is not the same methodologies, we might see one is positive, one is negative. In the same patient, if the patient has done it with a different lab, not followed up with the same lab, we find it challenging to then interpret. So that was my reason to bring out these points in today's small discussion, that we need to be aware of these limitations also of the testing methodologies.
So how many patients do you see who are diagnosed as rheumatology and then they turn out to be drug-induced?
So the percentage-wise drug-induced lupus, since in fact the drug which is no longer used is hydralazine, which was the topmost in terms of drug-induced lupus. So fortunately, that drug is almost banned, and the incidence of drug-induced lupus, if you look at in terms of literature, would be less than 3% in terms of autoimmune diseases. So it is not a common thing. Fortunately, with procainamide and hydralazine, these drugs no longer being used. But it's a point from the clinical history point of view, worth remembering that if it is a primary autoimmune disease versus a drug-induced auto, because prognostically a person who is drug-induced autoimmune disease would have a better prognosis once the drug is withdrawn.
Correct.
Any other question from panel or any other? Thank you so much, Dr. Bendre sir. We met after a long time. We are missing you in
Yes. Yeah. We are meeting after a long time. Also, I would also like to thank Dr. Patel. I'm also seeing sir after a long time. Hello, sir.
Thank you very much. Thank you. Thank you for recognizing me.
Yeah, no, of course, sir. How can I forget
After a long
you?
time.
Yes,
After
how
a
can I
long
forget you? Yes.
Patel
And madam as well. We were a part of that transplantation committee.
Yes. That's why we are missing you during LSC meeting.
I have met Bendre sir long back. If you
Yes,
remember,
hello, sir.
in Metropolis.
Yes.
Yeah. Thank you so much, sir.
Thank you.
Now, this is the end of the CME. Now, I request Joint Secretary, IMA Mumbai branch, Dr. Arvind Patel, to give a vote of thanks. Over to Dr. Arvind.
Thank you, Dr. Usha. Good afternoon to everyone. It is with privilege I propose the vote of thanks. I thank our esteemed speakers of today's webinar, Dr. Amol Kumar Patil, Dr. Preeti Doshi, Dr. Rujuta Hadaye, Dr. Santanu Sen, Dr. Pallavi Singh, and Dr. Rajesh Bendre. I also thank our acknowledged knowledge partners for today's webinar, Apollo Hospital, Johnson & Johnson Private Limited, Sanofi India Limited, and Newberg Diagnostic. I thank Mr. Deepan, Mr. Piyush, and Mrs. Vaishali from DigiShield, who gave us this digital platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Awad, member of IMA CGP, sub-faculty, for conducting this webinar smoothly and efficiently. A big thanks to Dr. Pankaj Bandarkar for being MMC observer for today's webinar. Last but not the least, I thank you all the delegates for participating in this webinar in such a large number and making it a grand success. Before I end, I would like to make an announcement that today we are having a grand installation ceremony of Dr. Anil Award in our spacious lawn of IMA Mumbai branch premise. I request all the participants to please look at the WhatsApp message and looking forward to see you. Thank you very much. Thank you all.
Thank you. Thank
So much, everybody.
Thank you all.
Thank
So
you.
thank you, Jitesh.
Thank you, Arvind.
Thank you.
Thank you, Jitesh, for your winning stroke.
Thank
Oh,
you.
you are in the hospital, sir.
Yeah,
Yes.
he's the emergency surgery. Surgeon is
हाँ?
Dr. Lad.
हो गया
surgeon.
हो गया
Operation.
कोलेसिस्टेक्टमी हो गया अभी घर जाके खाएगा फिर शाम को 5 बजे आएगा
आ जाओ
Okay,
Meeting
bye.
at 5.
So thank
Bye
you.
bye.
5 o'clock.
Yeah, meeting at 5. Yes, 5 o'clock.
Yeah.